nodding, someone is commenting. Okay guys, so let's start with the live session PYQ. See, few days are left, right? And yes, that we are preparing for it. We are prepared rather. So the best thing will be we are going to discuss important points. We are going to highlight the very important points over here with the help of on the basis of the questions which came in the last year. Hello, good evening. Ketan, Deep Katia, very good. Okay, so let's start with the first question, right? We are going to go from the easy one towards a little intense one, right? I am expecting the quick answers, right? We are going to spend only 1 or 2 minutes on each question so that we can wrap up within 3 to 3.5 hours. Yes, please. First question on your screen. A researcher was studying the effect of bioavailability of drug when applied topically. His focus was on amphipathic lipid. Very easy question. We are not going to go in much of the detail. Next question, guys. In the dye dilution method, the interstitial fluid volume is best measured by. Yes, I want your answers. Roshan, it is not stuck on my side. Please try and refreshing it. Hello, Dipanshu. Yes, please, answers. Answers, please. Okay, Dr. Rao saying C. Please remember interstitial fluid. There is a lag, I guess, in the answers. Guys, interstitial fluid. Okay, so just remember for now, there are going to be two methods in the dye dilution method. That is direct and indirect. Indirect. I for I. Remember, our intracellular fluid and interstitial fluid cannot be measured directly. That means we cannot put the dye only into the intracellular fluid or interstitial fluid. It has to go from the plasma, right? So that's why we cannot measure them directly, and that's why we measure them indirectly. So suppose this is the cell, this is the plasma, and in between we are going to have, this is the plasma, this is the cell, and in between we are going to have interstitial fluid. Both of this is called as extracellular fluid, and inside we are going to have intracellular fluid, right? If I put the dye over here, which dyes can measure the extracellular fluid, and which dyes are going to measure the plasma, which dyes are going to measure the total body water. Remaining ones are going to be measured directly, right? So yes, please, ECF and plasma. These are the three things which can be measured directly. Answers. Okay. Now, water is water. TBW, water means water, that is water ka formula. What is the formula of water? H2O. So for the total body water, we are going to use either deuterium oxide or tritium oxide, right? And antipyrine. ECF, for the ECF, I always tell you, remember the mnemonic Simon, okay? That is the ECF ka mnemonic, Simon. What is S? S for sucrose, I for inulin, M for MA for mannitol, and N for sodium iothalamate or sodium radioisotopes that we are going to use over here, right? So remember, if I have to measure interstitial fluid over here, what should I do? I have to measure this volume. I cannot measure it directly, so I'm going to measure ECF and I subtract the plasma, and that's how via indirectly I'm going to ECF minus plasma. I'm going to get the interstitial fluid, right? Plasma, very easy mnemonic. In the plasma, what is coming? Asthma. How is the asthma? Asthma means sky. It is blue. So please remember asthma, plasma, asthma. That is Evans ki blue dye. That is Evans blue dye. Right? So I need one thing from the Simon and I need Evans blue dye. So now tell me what is going to be the answer. What is going to be the answer? Yes, please. I need two things, that is one from Simon. I'm going to take the over here, look over here in the option B, D2O. We do not need D2O, we do not need D2O or T2O, right? We need inulin from the Simon and Evans blue. So answer over here is option A. Please remember it is the interstitial fluid, guys, not intracellular fluid. Ashutosh, right? Dipanshu, right, correct, absolutely correct. Let's move on. I'm not asking intracellular fluid, so that is going to be the option A. Okay, over here, again a paragraph question. So, paragraph question, one trick over there, please read the last line first and then go towards the story. Okay, that is my only advice for the paragraph type of questions. So, what is the last line? Which curve adjacent graph shows the transport of fatty acid across the enterocyte membrane? We do not have to even read the whole paragraph, right? Some female came, right? Investigation, gallstone was there, asymptomatic, again lifestyle modification. So that's why they asked her to reduce the fatty intake. So you have to identify which graph it is going to be for the fatty acids. Yes, please. Thank you, Apurv sir. Thank you so very much. Right. Answers, guys. B. Why B? Very good. It is the B. Why? Look over here. We are talking about fats or the other things, that is, the previous one was A, right? C, why C? Fixed law क्यों आएगा बच्चे यहाँ पे? Why the fixed law? See, over there what they are asking is about the diffusion. This is the diffusion curve, okay? So there are two types of diffusion, simple diffusion and facilitated one. Now, simple and facilitated. In this we need carrier. When we are going to need the carrier? When the substances are lipid soluble or water soluble. There are two types of substances. Lipid soluble substances can easily cross the membrane and water soluble substances, they need the carrier, right? Fat itself is a lipid. We do not even need to think of it, right? So as you are going to increase the concentration gradient, look over here, as you are going to increase the concentration gradient, the movement of the fats are going to increase. They do not need any carrier. On the other hand, if I tell you about the GLUT, which goes by the glucose goes by the GLUT, right? It is the carrier protein. After some time, it is going to get saturated, right? So water soluble substances who require the, yes, true, Dr. T, yes, true that. So that is going to require the carrier protein and they are going to get saturated. As they are saturated, there is going to be the saturational kinetics which is going to be seen over here, and that's why we are not going to talk in terms of glucose or GLUT over here, the fatty acid. So my curve is going to be curve A. There is no per se saturation, right? For example, if there was a lockdown, right, and if many people want to go from one place to another place, they can walk. Their speed will be slow, but n number of people can go at a time. But if you want to go by car or any other vehicle, there are limited numbers, though in India it is going to be much more as compared to the legal limits. But yes, then what we say that that they are going to vehicle ultimately going to get saturated, right? And that's why the speed will be high, but they are going to get saturated. So look over here, the speed initially of the facilitated will be high, but it is going to get saturated after some time. Okay, that is not the case in case of the simple diffusion. Let's move on to the next question. A scientist was studying the various proteins that are involved in the process of phagocytosis. Which of the following true about vesicular transport? This came in NEET 2020. Yes, please. Answers. Fixed law of diffusion, yes, but it is not applicable in the graph. You can say that. PDF will be available, don't worry. Thank you. Okay, I'm getting the answers. Yes, please. Vesicular transport, is it dependent on concentration gradient or not? If yes, then along or against? Please remember, vesicular transport, we divide that separately. So that means it is not dependent. It is having no correlation with the concentration gradient. If we talk about, let's say, the neurotransmitter release, from high to low concentration it will go. But if you talk about phagocytosis, then even if, let's say, outside there is one bacteria, inside two bacteria are already engulfed by any phagosomes, or we can say the neutrophils, then what is going to happen? It will keep on continuing the phagocytosis, right? So it doesn't depend on the, no, denied, it is not dependent on the gradient. Okay, so we'll do it quickly. There are two types of transport, active and passive. Active means against the gradient. That means if we are applying the energy, we can go against the gradient. And passive means along the gradient. We doesn't require any energy, right? When we come downhill, we can come rolling also, right? But when we have to go uphill, we need energy, lot of energy, right? So over here, active is divided into, yes please, primary active and secondary active, and then the vesicular transport. Primary active, if you are applying the energy directly, that means if the crowded bus or metro came, right, you have to go in because there is an exam, you have to go, right? Then what you do? Dishum, dishum. You make some space for yourself and reach to the destination. Same scenario in case of secondary. Suppose what happens that in the secondary you have a small kid, right, or anyone whom you love, but he or she doesn't want to fight. So what you do? You do dishum dishum for yourself and for that guy also, right? So what happens? Both of you reach to the destination, but the one with you, suppose that was child, the child is smarter. Why? Because he uses your energy to reach to the destination, isn't it? So that is nothing but the secondary active transport. Vesicular transport, it is not dependent on the concentration gradient. In the passive, we just now talk about the diffusion, right? Simple diffusion, facilitated diffusion, and along with that we do have osmosis. So I'm going to write diffusion over here and osmosis. Okay. Sodium potassium pump, yes, you can remember P for pumps over here, P for primary, S for secondary, S for symport, and with symport comes the antiport, right? Example is sodium calcium exchanger. Govind sir must have taught you the digitalis, digoxin, how they act, how they increase the contractility, right? So you can very well know that. Next, resting membrane potential of the nerve fiber is mainly because of which of the following ion? Yes, please. It's a very easy question, guys. Symport and antiport. Pseudo doctor. Why you are a pseudo doctor? All right. Yes, PDF will be provided. Don't you worry. Potassium. Very good. Superb. So just know potassium more than chloride, more than sodium, potassium pump. Sodium alone is having no role or negligible role in the RMP production. Please mind that. If sodium is written over there, don't go for sodium alone. It's the sodium potassium pump, our Nokia. is helping us, right? The sodium outside, potassium inside. 3 sodium out, 2 potassium in, ATPase. That is going to help us in the RMP production and not the sodium alone. Yes, Vinika, Shiv, Sangeeta, you guys are right, absolutely right. Saint, Dr. Rao, Kriti, superb. Let's move on to the next question. Now, if I ask you from the last question why the sodium is not having the role, because it is not permeable at rest unless the tissue, specific tissue, they're having the leaky channel. Please mind that. Next, again a paragraph question. Which of the following characteristic of axon is most dependent on its diameter? Remember, I don't know what happened to NBE, but they are making the paragraph questions. First thing, don't scare with the paragraph question. Right? Second thing, please read the last line first. Okay? Yes, please. Thank you. Thank you, Dr. MSG. Okay. Yes, please. So, research was going on, and which axon, how different and different species, right? So, characteristic of axon, most dependent on its diameter. Let's read out the magnitude of the resting membrane potential. Resting membrane potential, it doesn't depend on the diameter, right? It depends on the channel, their concentration, and which permeability basically, right? So, it is not dependent. The duration of refractory potential. Refractory potential, in the refractory we cannot give the stimulus, that is dependent on the refractory period. That means we cannot give the successive stimuli in that period, but it has no correlation with the speed per se. Conduction velocity. Now understand, over here if I say there are two nerves, right? If the diameter is wider, what is going to happen? Suppose there is one hall, okay? In one hall, 10 students are sitting. The door, only one door is opened and all other doors are closed. And I'm noting down the time. How much time it takes to students to get out of that room. And then if I open, let's say 2 or 3 doors, and then I see how much time it is taking. Definitely when there are more doors, that means more space is available. At that time it will take less speed, right? So same over here, if the diameter is wider or having larger diameter in the nerve, definitely the transport is going to be very, very faster, and that's how we are going to get our answer. Overshoot. What is overshoot? If I draw the action potential over here, suppose this is the 0 level. After the 0, whatever is part of action potential is coming, that is known as the overshoot. But it doesn't depend on the overshoot that what is going to happen, right? The diameter has no role with the overshoot, because the action potential is following all or none law. Yes, Dr. Strange, don't worry, everything will be covered. If you are reading for NEET PG, everything will be covered for sure. Okay. Next question, please. Yes, large diameter, more conduction. Yes, right, Dipanshu. Next, which one of the following is true statement regarding the action potential? Let's see. The depolarization is a result of outward movement of potassium ion. Is it true or not? The action potential occurs when the potential reaches threshold at -75. Resting membrane potential -95, and action potential occurs due to sudden opening of sodium channel. Yes, please, guys, answer. Thank you, Dr. Gaurav. Yes, D. I got the right answer. That is D. Why D? Understand that when we talk in terms of action potential, first of all, when we give threshold stimulus, the sodium channel, few sodium channels will open. The few opening of sodium channel will stimulate the further opening of another new sodium channel. This cycle is known as, yes please, we have done this in the lectures, this cycle is known as Hodgkin's cycle, right? And it is the positive feedback mechanism, okay, that is going to occur as soon as we reaches to the firing level. So there is going to be the sodium influx that is going to occur, due to which the depolarization will take place. Will reach to the spike. After the spike, two things are going to occur. Whichever channel is open, just close it up and open the potassium channel. So over here we are going to close the sodium and we are going to open the potassium, right? So potassium efflux will start, but what they are asking is the truth statement. The depolarization won't be occurring because of the potassium ion. It is the repolarization, isn't it? Then the action potential, the threshold. What is the threshold value? Over here, the threshold should be plus 15, and we know that the when we say that the RMP of the nerve, that is going to be the minus 70 MV, and threshold, to reach the threshold we have to reach to the minus 55 MV, right? This is the RMP, so this cannot be the threshold value, right? It should have been minus 55. Yes, good. So the resting membrane potential, it is not minus 95. We discussed that. Action potential occurs due to sudden opening of sodium channels. That's true. Positively charged ion coming inside the cell will make the cell positive, right? As the cerebellum is doing in your life, isn't it? So keep that positivity spreading. I know all of you are anxious. We have also gone through this phase. So look, there is no shortcut. We all have to go through this phase. Just say all is well and move on, right? Don't worry, whatever is happening over here is for your good, right? Keep the spirit, keep the perseverance, right? Many of the students, they will give up, they will get anxious. So only advice over here is convert your worry time into study time. Don't let your worry to, take off your time, okay? All right. Performing amphibian experiments, right? Increase in the threshold. Now what it is saying, that student found an increase in the threshold level, applying sub-threshold slowly rising stimulus. Okay, so I'll just give you two things. It is not refractoriness. Electrotonus means it is the local potential, and local potential doesn't talk about the threshold at all. We know that, right? All is well, right? Good evening, Dr. Rahul. I guess you missed some question, but no worries. Okay, so accommodation and adaptation. Remember, accommodation talks about sub-threshold stimulus, right? Accommodation always occur before the action potential. There is no action potential, rather it is taking more threshold or more stimulus to reach to the action potential when we talk about adaptation. So AP is coming in this. So please remember, it occurs after the action potential has been generated. Action potential will generate at the first time, right? But if you give these threshold or more than threshold stimulus, that means supra-threshold stimulus. Okay, so adaptation always going to talk about threshold or supra-threshold, and it is the continuous stimulation like this. Okay, so let's see over here. So suppose I give the continuous stimulation. What is going to happen over here? Whenever there is going to be a flux, that means change, then only I'm going to see the response, right? But over here, meanwhile, the response will be reduced. That is known as adaptation. So please remember, in the adaptation, AP should be seen before, and once the AP generated, but still the stimulus is same, the nerve is going to adapt, okay? So if they are saying sub-threshold, go with the accommodation. If they are saying supra-threshold, go with the adaptation, okay? The mnemonic is supra, P for P. Go for. If you see supra-threshold, go for adaptation, okay? Let's move on. Like we were adapted to Viva insults, true that. All right. If the nerve fiber is damaged but the nerve sheath remain intact, What is it called? Hanji, answer please. Eight. Okay. So let's see. There are two classifications. First of all, we should know what is the anatomy, right? You must have learned anatomy very well. Neurotomasis. Okay. See over here, there is going to be the axon, right? Axon is going to have the covering. That we are going to call as the endoneurium. Then there will be many axons coming together which will be forming the fascicle. Fascicle will be having the covering that is known as, yes please, perineurium. Okay. This such fascicles, many fascicles, they are coming together, they are going to form nerve, right? The whole nerve, I'm not saying nerve fiber, I'm saying nerve, right? Which are containing many fibers, many fascicles. It is going to contain or having the covering that is known as epineurium. Remember, the covering acts as a track and the axon in between act as the cargo. Okay, so let's take the example of railway. If the railway track is damaged, nothing, no railway is another railway. If the railway is normal, we cannot help it out because we cannot transport it because the pathway is damaged over here. We cannot allow the railways to go from that track. Okay, but what if one railway is having or one cargo is having some problem? No issues, we'll manage with another cargo, right? So that is what happens in the nerve also. If the track is damaged, that means covering is damaged, the another cells, nerve growth factors, whenever are stimulated, Schwann cells or the oligodendrocyte, they do not know in which direction they have to go. Okay, so in the repair also it is going to be bad. So please remember EP. Okay, right. So over here what they are saying, if I tell you that the axon is damaged, right, then what it will be called as, if there is only mechanical suppression, if what it will be called as, Saturday night palsy, crutch palsy, Hanuman palsy, all these are compressions, right? Suppose there is a compression on the hand because the people are sleeping whole night on the hand. What is going to happen? It's just the mechanical compression. There is no damage per se, right? That is known as neuropraxia. Okay, that is known as neuropraxia. But if I said that axon is damaged but the track is intact, that axon is damaged, so we are going to call it as axotomasis, and that's what it is asking. Nerve sheath remains intact, that means the covering is intact, right? Only the axon is gone, isn't it? So it is going to be the axotomasis, and whole three are gone, then we call it as neurotomasis, right? Axopraxia, there is no such term, it is just made up term, right? So you can see over here, this is the normal one. This is the normal one. If there is mechanical compression, after some time, depending on how severe it is, after some time it is going to repair very quickly, right? 100% recovery will be there, just a tingling sensation for that matter. Meanwhile, it is going to occur. Axotomasis, you can see the axon is damaged over here, and neurotomasis, there are two different parts are going to occur. That means axon as well as the nerve sheath is gone. Okay. Yes, nerve sheath is intact. That means the covering is intact and the axon is damaged. So that's why we choose PYQ before, if I give you the rapid revision, you'll be thinking that, yes, I know this point. But when the question comes, actually what happens? The mind flips up, right? Okay. I had some memes for that. I'll put it on the group itself. Okay. Chalo. We'll study right now. When medical students were performing the amphibian experiment again, right, what he found out, nowadays the practical questions are coming, so please, INI-CET as well as the NEET is asking this question. So yes, 10 milliseconds was the contraction period, was 40 milliseconds, and the relaxation period was 20 milliseconds. The tetanizing frequency, or we call it as MTF, that is minimum tetanizing frequency, that is 1 upon contraction period. And remember please, The unit will be hertz. That means this is in seconds and not in milliseconds. Okay. It's not boring subject, geopolitical. We'll make it interesting, don't you worry. Okay. Yamini Priya. Yes. So answer batao bhai. All right. So 1 upon contraction period, over here we are not concerned with the latent period, we are not concerned with the relaxation period also. So 1 upon contraction period, but they have given us the 40 milliseconds, right? 1 second, that means 1000 milliseconds upon 40. That I'm going to do, right? That is, the answer will be 25 hertz. Now can you hear me, guys? Can you hear me now? Please let me know yes or no. Can you hear me now? Yes, okay. Let's go on. There are many answers, D, B, A. All right. So just remove everything from your head, the confusion, right? The confusion I'm talking, not the syllabus. Just remember Seno. Sensory neuron, when I'm going to talk about, it is going to be the nodes of Ranvier and motor nerve. About the motor nerve, please remember it is going to be the initial segment. So whenever they are going to ask you about the generation of action potential, just remember Miss Senorita. Okay. So what is Miss? Miss is motor neuron. Always remember it is going to be the initial segment. Why? Because it depends on the concentration of sodium channels. Okay. And Seno means sensory neurons. They are going to produce Senorita, NOR, that is nodes of Ranvier. Okay. Why? Because their body, when we talk in terms of sensory neurons, at that point the DRG is present near the spinal cord, okay, or we can say it is near the spinal cord. So that's why whenever, suppose I'm feeling the sensations over here, I need to generate the action potential at that site only. It cannot wait till here, right? So that's why the answer is going to be the nodes of Ranvier, since the initial segment will be very, very far. Okay. So look over here, this is going to be the initial segment. Suppose if I say, what is the initial segment? The axon, wherever it meets to the body, the junction is known as axon hillock. Okay, so this is known as axon hillock. The first part over here, this first part over here is known as initial segment. Initial segment, okay. But remember, always remember, the initial segment should be near the soma. The soma of the pseudo-unipolar neurons of the sensory, they are very far, and that's why we have to go through this nodes of Ranvier. Okay. Yes, it's the first node of Ranvier. The answer over here is first node of Ranvier, since they ask about sensory neuron. Okay. Right. So please remember that if the motor neuron is there, then the answer will be, yes please, initial segment. If it is the sensory neuron, you can remember Miss Senorita. Don't forget her. Okay. Alright, next question. The graph below represents the relationship of chest, lungs and both together with respect to transmural pressure. So which one of the graph is the of lungs, which graph is of chest wall, and what is this X over here? Yes please, answers. Now remember that this is the transmural pressure and this is not the intra pressures. Okay, there is a difference between intra pressure and trans pressure. So whenever we talk in terms of trans pressure, we have to do in minus out in the adjacent layers, right? So please remember, when we talk in terms of, let's say, lungs. Okay, so over here let's talk about the lungs. Suppose this is the lung. It's a combination of alveoli. Over here it is going to be the intra-alveolar pressure. Is going to be the intra-alveolar pressure, right? If this is the pleura, it is going to be the intrathoracic pressure or intrapleural pressure. When I'm going to talk about the transpulmonary pressure, I have to talk in terms of these two things, right? So this is going to be the transpulmonary pressure. That means I have to do IAP minus ITP. Remember, the IAP is going to be positive or negative or even zero. It depends upon what thing. It depends upon what phases are going. But the ITP is always going to be negative. And when you're going to do any X amount minus negative Y amount, negative always going to come together and make it positive, right? So please remember, the lung value will always start from the positive. That means after the zero. Okay, and the chest wall, when we are going to talk in terms of chest wall, it is going to be the ITP minus atmospheric pressure, isn't it? Atmospheric pressure is always positive, but you are subtracting it, right? And plus the ITP, I told you, it is going to be negative. In the resting condition, it is going to be minus 2.5, right? Whatever it is. But over here, the atmospheric pressure, which is positive, we are subtracting it. So it will start from negative. So please remember, the chest wall transmural pressure start from negative. Okay, even in the exam, if you forget, please remember, C comes first, that is chest wall comes first. So this first graph is going to be of chest wall. Don't panic in the exam, right? And this is going to be the lungs. Okay, and whatever graph is in between, that is going to be the average of both of these. Now there is going to be a point where it is going to be equal. That means the lung pressures, transmural pressure across the lungs and transmural pressure across the wall, it is going to be equal. You can see over here, this is equal but opposite. Over there, the movement will be minimum, and that pressure is nothing but the functional residual capacity. Functional residual capacity. Can anybody tell me this pressure at this level is called as? This pressure is called as, and this volume is called as? Are we contracting any muscle during this time? At the FRC, are we contracting any muscles? Yes, please. Are we contracting any muscles? No, we are not contracting any muscles, especially in the resting condition. When at the end of expiration the phase comes, that is known as the functional residual capacity that is going to remain inside our lung. So that means our lungs are going to be completely relaxed at that phase, right? As you will be relaxed after the exam. So the lungs are relaxed after the expiration, right? So at that time, we are not contracting any muscle, we are not using any ATP, and that's why this is known as relaxation volume, as well as this is the pressure at that point will be called as relaxation pressure, right? And so over here, the curve A is of chest wall, right? The curve B is of lung, and this point we know that this is the FRC, that is the relaxation point, right? So yes, please, what is the answer over here? So the lungs, X is the chest wall, A is the chest wall, the lungs, and the functional residual capacity. So the answer over here, the correct answer over here is option C. NO, what is no? For what you wrote no, Dr. Rao, and your drug of your drug of choice. All right, we do have antidotes. Yeah. All right. C. Right. Absolutely correct. Venika, Ravi, drug of choice. All of you. Yes. Let's move on to the next question. Oxygen dissociation curve will be different when it recorded when the protein hemoglobin and myoglobin. Myoglobin oxygen dissociation curve. All of the following statement are true except, that means we have to find out false statement over here. Now the NB people got to know that you know about hemoglobin dissociation curve, everything about hemoglobin dissociation curve. They started asking the question on myoglobin curve, isn't it? Right. Yes, please. Answers. Answers, please. Right. So I'll just show you a diagram over here. Remember, the myoglobin is going to have the higher affinity, and that's why in less pressure also, as compared to the hemoglobin, in less pressure it is going to get saturated very quickly. But remember, it is on the left side of the hemoglobin curve. Hemoglobin binds to 4 molecule, that means 8 atoms of the oxygen, right? But remember, this is going to bind to, it is present in the muscle, that's why it is called as myoglobin. It is going to bind to 1 molecule or 2 atoms of oxygen only, right? It is having very high affinity. Affinity means attraction, so it won't give up the oxygen very easily, right? Hyperbola, very good. No cooperative binding, true that, very true. Yes, so let's go towards the option. It is having higher affinity than hemoglobin, that's true. In less pressure, it is going to bind to more oxygen. Does not show cooperative binding, that is also true. There is no use of this cooperative binding. Why? Because it is binding only to the one oxygen molecule, right? Curve is right to that of the hemoglobin dissociation curve. It is towards the left. Curve has steep rise below 5 kilopascal and has slower rise after 5 kilopascal. That is also true because it will get saturated till that point. Even if you do not know that last line, you can make very well that the C option is correct only, right? Isn't it? So you can see over here, around somewhere down here, it will be 5, right? The curve over here is very steep, right? But after that, it is going to be flat. Why? Because the saturation occurs there. Let's move on. Okay, so this is the hemoglobin oxygen dissociation curve. Recently, they ask about the many questions like increase in the temperature. On the exercise, they have asked the question. So please remember, exercise, that means it is going to have the anaerobic metabolism, increases glycolysis, but the demand is very high. So that's why it is going to simultaneously produce the lactic acid 2,3-BPG, which will shift the graph towards right. Because of the lactic acid, the pH will be low, right? All these things are going to occur during the exercise. In the exercise physiology, they can ask about the oxygen dissociation curve, isn't it? Okay, let's move on to the next question, guys. Over here, just see over here, the crescendo decrescendo pattern. Even if you do not read the question, this is the only pattern. The graph itself is telling you many things. So look in the graph, and they have given you crescendo decrescendo pattern as a hint. So 45-year-old man suffered with head injury in automobile accident, right? Pattern of breathing they have asked. So this type of pattern of breathing followed by apnea. Hyperventilation apnea, hyperventilation apnea. In which case it is seen very good. Kind stroke. Physiologically it is seen on high altitude. As we go on to the high altitude or in kind stroke, what happens is there is hypoxia which is occurring or which is taking place. That's why patients start hyperventilating. There is gradual increase in the breathing, right? But with that, what is happening? More oxygen is coming inside the body, but because of the hyperventilation, there will be more carbon dioxide wash out, isn't it? So if the carbon dioxide is washed out, what is the main stimulus for respiration? It is the carbon dioxide, right? Why? Because it stimulates both peripheral as well as central chemoreceptors, right? Again, one question. Who is the main stimulus for respiration? It is the carbon dioxide in the normal person, right? If the carbon dioxide is washing out, right, so drive will be reduced, and that's why the patient will be having apnea for some time. In the apnea, the carbon dioxide again builds up and stimulate the respiratory system back again, and that's why the hyperventilation comes back, right? So hyperventilation followed by apnea, hyperventilation, that is gradual increase and decrease, crescendo decrescendo pattern. Yes, CO2, it is the CO2. That depends, Pratik, that depends. They haven't mentioned head injury is at the brainstem level or at what level, okay? So unless and until the level is mentioned, we cannot say it is the Biot's breathing. Suppose if there is a problem, let's say above the pons, right? So our regulation is not going to get hampered, okay? So understand that. Only if the brainstem is affected, especially the pons, then only the regulation will be hampered, and that will be the irregular breathing, okay? In the Biots, you cannot see the crescendo decrescendo pattern. There will be no pattern whatsoever. It is going to be irregular depth, irregular rhythm also, okay? Let's move on. Okay, 58-year male, OPD में आया, right? Pulmonary function test करवाया. History of smoking for 15 years. COPD, given everything. Pulmonary assessment, everything will be less. In the obstructive disease, the FEV1 will be less, and especially what happens in the obstructive or restrictive disease. When we are going to talk in terms of obstructive restrictive, remember FEV1 percentage. When we are old, everything is decreased, right? So this index nowadays they are asking about name also, so please remember Tiffany-Pinelli index, that is FEV1 upon FVC. The numerator is decreased in the old, that is the obstructive lung disease, right? In the restrictive lung disease, what is going to happen? In the restrictive lung disease, there is a restriction. So FVC, initially what is going to happen? The FEV1 will be normal, but the FVC will be decreased. So in the initial phases or in the mild phases, the RLD will be having, okay, I'll write over here, the RLD will be having increased or normal FEV1 percentage. Later on stages, both are going to decrease, but remember, both when decreases, either it is going to be normal or increased. You can remember in the old, FEV1 percentage is reduced, okay? So both are given. FEV1 is given, that is numerator is given, and both the percentage is also given, okay? So what is going to happen over here? both are going to reduce. So less than 0.7, that's true. Less than 0.8 or 80%, that is also true. Over here it is not going to be more than 0.7, which is normal. It is not going to occur. 15 years का smoke history है, normal कैसे रह सकता है, right? So it cannot be normal. It should be FEV1. So the answer over here is option A. All of you are absolutely right, right? Just see over here, even if the diagram is given, you should be able to get it right, okay? So over here you can see just the percentage, FEV1 versus FVC, which is normal. Over here the percentage is decrease in the old, and it is going to be more or normal depending on what type of restriction it is, mild, moderate, severe, and how long, okay? Either it is going to be normal or increased. Right. Gold criteria. Superb. Next, at the end of quiet inspiration, alveolar pressure is normally, yes please, how much it is the alveolar pressure they're asking. There are different types of pressures. Answers please, guys. So suppose I'm drawing the pressures and volume. What is going to happen? At the beginning of inspiration, it is going to be 0, right? As soon as the person start to inspire, it is going to be negative. During inspiration, please remember, during inspiration we have to suck the air. It is not the actual thing, but we have to suck the air. That's why negative suction pressure is required. So during inspiration, IAP will be negative. During expiration, it should be positive. It should be positive, right? +1 and -1. Yes, the answer over here is, but remember over here they haven't asked us about the during phase. When I'm going to ask about the end of inspiration and beginning of expiration, beginning of expiration or end of inspiration, over here end of expiration, what they're asking, please remember, read the question very carefully. End of quiet inspiration. It cannot be positive. It cannot be positive, right? It is going to be 0. It is going to be 0 centimeters of water or 0 mmHg. Both are the same, okay? So if they do not, they haven't asked about the during phase, you don't have to think about anything. At the end of, be it the inspiration, be it the expiration, quiet ones, they are going to be 0, okay? Both 0, right? So look over here. So this over here, we just now drew the diagram of it. During the inspiration, it is the diagram from Ginong, right? So you can see during inspiration, we have to have the negative pressure so that our lung can have the more air. Why? Because understand, suppose this is the alveoli in the lung. If it is having -1, outside it is 0, there is a gradient towards the lung, and that's why the air is going to come inside, right? During expiration, what happens? Suppose this is the alveoli, right? During expiration, it is going to be +1 and 0. So the gradient is towards outside, from high to low concentration or pressure, right? Over here we are talking about pressure. So always go from higher to lower pressure, right? Over here they have given the intrapleural pressure. Again, everything should be negative during the inspiration, suction pressure, right? So as we inspire more and more, it is going to go towards negative. How much? Around -6 mmHg. And during expiration, it is going to be positive. When the positive pushing pressure is there, then only the air is going to go out, right? And this is the volume. Volume increases at the end of inspiration. That is known as tidal volume, okay? And then decreases during expiration, right? So and we ask this type of question rather than knowledge, this also see your presence of mind. So please have the presence of mind at the time of exam, right? So yes, whatever it is, we have to go through, right? Next question. During plethysmography, which of the following pressure changes occur as patient expire with the closed glottis? Yes, please. Right, Dr. Rao, absolutely correct. So, first of all, we should know about the plethysmography. Okay. So look over here, what is going to happen? We ask the patient to sit into the box and ask him to inspire, expire. Now what is going to happen? There are two things. First thing is lung and box. Okay. Let's say the pressure over here inside the lung and box and the volume. Okay. First thing, we know Boyle's law. According to Boyle's law, the pressure and the volume, they are inversely proportional to each other, isn't it? Now what is going to happen when the person, we say inspire, what is going to happen during what they have asked us, that closed glottis is there but he is expiring. We know, let's see about the expiration itself. We know what we talked just now, that during the expiration pressure should be positive. Okay, so you can remember X as positive, right? So positive pressure. So what is going to happen in the lung? There will be positive pressure. But understand, the pressure is maintained in the box because he's inspiring and expiring in the box itself, right? So the box pressure decreases. And what is going to happen according to Boyle's law to the volume? The let's say pressure increases over here and box pressure decreases. The volume is going to decrease over here and the volume of the box is going to increase during expiration because the air is going to come out, right? So yes. So this should be the case, and in the inspiration, the reverse is going to occur, right? You can see over here, mouth pressure and box pressure. As the mouth pressure increases, the box pressure is going to decrease, right? And vice versa. If I say the box pressure is higher, it is increasing, what is happening to the mouth pressure? It is decreasing. Mouth means it is connected to basically the lungs, okay? The pressure transducer is put into the mouth. Right. So what is going to happen if he expire? The pressure in the lung and the pressure in the box. The pressure inside the lung is going to increase. Valsalva maneuver, right? So the pressure inside the lung increases and the box decreases. Yes, you guys are absolutely right. It is none other than option C, right? So yes, pressure changes are there, lung changes are there, everything is there. Next question. A patient with respiratory volume 500, volume is given 500, intrapleural pressure is given -4 centimeters of water before inspiration, -8 at the end of inspiration. That means we have to measure the difference between these two and then we have to calculate the compliance. Compliance, formula of compliance, guys. Compliance is equal to delta V by delta P. That is, how much volume change is occurring per unit when you cause per unit change in the pressure. So volume we know it is 500. So if we talk about this, the difference over here is 4 centimeters of water. So we can divide it by 4. How much? The answer is very, very clear. It is going to be 125 ml per centimeters of water. Okay, right, you guys are absolutely right, Ankur, Dr. Rao, Vinika, yes. Okay, let's move on to the next question. Which of the following is higher at apex of the lung than the base? The broad side is always base, right? At the base, remember, both is higher and both are lower. If I say V upon Q, V is ventilation and the blood flow, that is nothing but the perfusion. Okay. Now understand, both are more. Since there are more alveoli, more compliance at the base, so ventilation is going to be more. But remember, the perfusion is going to be much, much, much more due to the gravity. In case of the apex, what is going to happen? The ventilation is less. Agree on that. But due to gravity, again, the Q is much, much lesser. Okay. So if you calculate the ratio over here, what is going to happen to the ratio? Due to less denominator, the ratio will increase. VQ ratio will increase, and over here the ratio will decrease. What they are asking, higher at apex, the ventilation is higher at base, perfusion is higher at base, PCO2 is maintained everywhere, right? It is a partial pressure, it doesn't depend upon the area and all, right? So yes, the answer over here is option A. I got the answers. Iron, drug of choice, Ankur, Vinika, all of you are correct. Dr. Rao. Good. Let's move on. All of the following are false except vagotomy, mid-pontine lesion causes rapid shallow breathing. Lesion below the medulla causes apneusis. Between the pons and medulla causes ondine, and pontine lesion causes slow and deep breathing. Yes, please, answers. So over here the PBC, VRG, DRG is going to be there, right? What they cause? They causes on-off center. This is the on-off center. First of all, PBC is pre-Boltzinger center, which is the pacemaker, but it is going to generate irregular rhythm or irregular shallow respiration. To make it normally also irregular and shallow, right? To make it depthful and regular, we need apneustic center, pneumotaxic center. Apneustic center increases depth, right? Why? Because it is containing eye neuron. It always stimulates the medulla. But the problem is, if you continuously stimulate the medulla, it will continuously stimulate the eye neurons and it will cause the inspiratory spasm, which is known as apneusis. So to prevent that, we do have two inhibitory control from the pneumotaxic center and from the stretch receptors of the lung, right? That is going to be the negative control, and which will maintain the pneumotaxic center, especially it maintains the rate. This was the question which has been already asked, so please remember that. Okay, so what is going to happen? Bilateral vagotomy, if you cut the vagus and the mid-pontine lesion is there, that means there is no control on the apneustic center. Rapid and shallow breathing, no, there will be apneusis in this case. Below medulla, if you cut below medulla, there is no on-off center. So what is going to happen? No respiration. Person will be expired, right? So below medulla, there will be no respiration. Lesion between the pons and medulla causes ondine curves. No, remember, ondine curves, for that we require cortical centers. Ondine curves, in that what is going to happen? That all these centers, the brainstem injury will be there. Brainstem cannot work. Somehow the cortical centers, they can provide the signals to the lung. That means only voluntary. Ondines means only voluntary control is remaining, so he has to breathe voluntarily. Okay, and the most common cause of death is not the lack of oxygen, it is the lack of sleep. Remember, as soon as the oxygen is falling down, as soon as the person sleep, the oxygen will be falling down and there will be apnea, so his RAS will be activated and he will wake up. That is the sleep apnea, right? So the most common cause over here in the ondine curves, that is going to be the lack of sleep. Anyways, so the correct answer over here, mid-pontine lesion causes the slow and deep breathing. That's true. It is going to cause only, they have told us mid-pontine lesion, but remember the vagus is intact over here. Okay, so it is, I don't know for what you answered it as B and C. The correct answer over here is D. Remember, ondine curves, lesion, it is not between the pons and medulla. Lesion is above pons. Lesion is above pons. That means the pons, whole the brainstem is not working. Basically, what I mean to say is the whole brainstem is not working. Only the cortical centers are giving the signals to the lung. Okay, and if there is lesion, some of you answered the B, lesion below medulla causes apneusis. No, if there is a lesion, bilateral vagotomy plus mid-pontine lesion, that will cause apneusis. Okay, below medulla everything will be gone. Okay, no signals will reach out to the lungs. Okay, let's move on to the next thing, sleep apnea, right? Cardiologist suspecting exertional angina. Okay. Stress echo kara. So check the blood flow. Following phase. Does the left ventricular subendocardium receives the blood supply in the coronary arteries? And they have given us the ECG waves. Now understand, even if you just know that the P wave causes atrial depolarization, the QRS is for ventricular depolarization, and the T wave is for repolarization. Repolarization will be followed by relaxation. It will be followed by relaxation. Now understand, heart is the only organ, because let's say these are the heart muscle. Heart is the only organ who is going to get the blood supply in the diastole phase. Why? Because suppose this is the blood vessel. The blood vessel present in between the nylon stocking like arrangement of the muscle fibers of the myocardium. Now if I constrict the muscle, what is going to happen? During the systole, the vessel will be squeezed, it will be compressed, the blood flow couldn't occur during that time. During the diastole, the vessels are going to open up back again because the muscle is going to give them that space, right? So during diastole, the blood supply will be reaching towards the subendocardium. So that's why the diastole occurs after T wave, remember. So the answer is very, very easy over here. That is nothing but option D. Yes, all of you are right. Let's move on to the next question. Yes, please. The researcher scholar in AIMS. Okay. Paragraph question. The drug expected to act which channels? So they are asking about drugs. He records the action potential graph throughout experiment. Okay. Administrating drug which is affecting slope 0. Yes, please. Answer. The answer over here is going to be fine. Let's discuss. This is the cardiac action potential. Basically, in the cardiac muscle, we are going to have nodal tissue as well as cardiomyocytes, right? The myocyte will be having plateau phase, right? Over here, this is going to be the myocyte. Yes, I'm getting the answers, but there are two different answers over here. Now, whenever you're going to see the slope and see from where it is starting, the RMP of the cardiomyocyte is minus 90. Please make sure that. Okay, so there are two hints that this is not the cardiac muscle action potential, it is the nodal tissues action potential. What are the hints? First thing, there is no plateau phase, right? There is no plateau phase in the nodal tissue action potential. In the myocyte, there will be the you can say the plateau phase. Okay, and plus the RMP over here is minus 40 to minus 60 in the nodal tissue, which is unstable, which is stable in case of the myocytes. Okay, and when we talk in terms of the phase 0, it is going to be the calcium L channels, right? Long acting channels. Over here, early closure of potassium, then sodium funny channels, that is HCN gated channels, and the calcium T channels, which causes the slope to go towards minus 40, from where the autorhythmicity will occur. The action potential is going to fire up. Why? Because the minus 40 is the firing level of this nodal tissue, and as soon as it reaches to the spike, whatever channels are open, close them and open potassium channel everywhere in the body. Okay, so over here we are going to open up potassium, we are going to close the calcium L channels. So we have to give CCB over here. So they are asking about phase 0. Block the voltage gated sodium channel. There is no correlation of sodium over here. Block the hyperpolarization influx. Block the calcium channel and block the potassium channel. So please remember, he is studying on blocking the calcium channels. Ravi Gupta, it's not the sodium. It is the calcium. Why? Because it's not the cardiomyocyte, it is the nodal tissue. Okay, again the answer is not A, guys. There is no correlation of sodium. These are not voltage gated. These are which channels? They are leaky channels. Yes, option C is the correct answer. Let's move on to the next question. All of the following are true about myocardium except increased sympathetic activity causes positive inotropic, negative lusotropic. Okay, positive inotropic, positive lusotropic. Then lusotropic effect is mediated by cyclic AMP dependent pathway, increase calcium uptake from ECF to cytoplasm, decreases lusotropic in absence of sympathetic stimulation. True except. Yes, please. Answers. True except means false statement we have to find. Now, whenever there is stimulation of, let's say, cardiomyocyte, now what is the lusotropic effect first of all and inotropic effect? Inotropic will decide the force of contraction. Whenever we activate sympathetic, please remember everything is going to be positive, right? Positive inotropic, positive bathymotropic, positive dromotropic, positive chronotropic, and even the positive lusotropic. Lusotropic means, yes, lusotropic means the relaxation of the muscle. If you are contracting quicker, you have to relax the muscle quicker, otherwise it won't be able to contract in the next cycle, isn't it? So what is going to happen over here? Just please remember, this is the sarcoplasmic reticulum, and on the sarcoplasmic reticulum we do have sarcopums or calcium ATPase. This calcium ATPase is inhibited by a protein known as phospholambin. So it is the negative regulator in the normal phase. But understand, as soon as your sympathetic system is activated, sympathetic system causes increase in the cyclic AMP, and increase in the cyclic AMP causes inhibition of the phospholambin. That means there is no one to inhibit the calcium ATPase. The calcium ATPase will be acting faster, right? And if it is acting faster, more and more calcium can go inside the sarcoplasmic reticulum within less time, and that is nothing but, that means there will be no calcium available for the binding of the actin and myosin, right? There is no one to remove the tropomyosin. Why? Because no one is binding to the troponin, right? Calcium troponin complex will be removing the tropomyosin. No calcium, no removal of tropomyosin, there will be no contraction. That means relaxation is going to be faster, right? So increase in the sympathetic activity. Over here, lusotropic effect is mediated by cyclic AMP dependent pathway. That is true. Increase in the calcium uptake from the ECF to the cytoplasm decreases lusotropy in the absence of stimulation. That is also true. Okay, over here they are saying increase in the sympathetic activity, positive inotropic and negative lusotropic. It is the positive lusotropic, please remember that. Okay, not the negative lusotropic, just now we discussed. So simple funda, please remember, in the sympathetic system cyclic AMP will be activated. It is going to cause all the positive effects inside the heart. Okay, yes, calcium induced calcium release, yes, that is also there in the cardiac muscle. It is also present in the smooth muscle also, right? CICR, right? Let's move on to the next question. The pressure changes in the jugular vein during a single cardiac cycle were measured. Which of the following interval denotes the period of ventricular systole? Ventricular systole, yes please, answers. Now remember, there are three waves, two descents. A, C, V are the waves, positive upstrokes. X and Y are descents, right? Over here, I'll just draw it. X and Y is going to be the descent. Smaller one so that you can see X and Y. Alright, so A, C, V. Now please remember A for atrial contraction. Now, this is for tricuspid valve bulging. This tricuspid valve, whenever it is going to come down, that will give X dash. Okay, so this X is divided into two. Please remember, if only X is given, that is the atrial relaxation. okay? And this X dash is because of tricuspid valve coming back towards its normal position. This is because of bulging of tricuspid valve, because remember the jugular vein and the right atrium, they are connected together. There is no valve in between. So if I want to know the pressure inside the right atrium, I'm going to measure the pressure inside the jugular vein. So that's why if there is bulging of the tricuspid valve, what is going to happen? Definitely if there is bulging of tricuspid valve, slightly the right atrial pressure will increase, and that's why jugular pressure also increases. V for venous return, that means the atria is getting filled up, and Y is for atrial emptying. I hope you can see that. Atrial emptying, right? What they're asking, ventricular systole. Ventricular systole, that means whenever the ventricles are in systole, please remember the atria must be in the diastole. So when the atria is going to go in the diastole, atria is going to relax. So when the atria is relaxing at this phase, isn't it? So from A to X, we can say X descent, right? A to C. In the A to C, the atria will be relaxing, right? That's true. A to V. A to V, that means over here, this cannot be this much whole bunch of the bigger, you can say it is very, very big. In the venous return, the pressure will be increasing. So we cannot say that the ventricular systole is occurring there, because remember, in this phase, there will be isovolumetric relaxation already started. Okay, so the ventricles are relaxing at this phase. So we cannot say this is the answer. X and Y descent. In the Y, the atria is emptying, that means it is contracting. So that is not true. The ventricle must be in the diastole, right? So ventricular systole, over here, the contraction is occurring of the contraction, I mean the systole is taking place, but remember the contraction is isovolumetric, right? So this is not the proper systole. So if I have to choose between A and D, I'm going to go with option D. Why? Because the ventricular systole, that means I have to check for the proper systole. I have to check for the proper systole and not for the isovolumetric contraction. If I have to choose between ventricular systole proper, that means whenever the ejection is taking place, and that is taking place in this phase, right? In this phase, the atria is completely relaxing. So that's why I'm going to go with the option D. Yes. Ankur, absolutely correct answer. Ayan also right. Let's move on to the next question. What will happen when the common carotid arteries are occluded on the both sides? Yes, please. Suppose this is the baroreceptor and this is the common carotid artery, right? What is going to happen if you block the common carotid artery? That means we are blocking here, right? There is no blood supply which is going towards the baroreceptor. If no blood supply is going towards the baroreceptors, what is going to happen? The baroreceptors are going to cause no stimulation, right? Baroreceptors, they are stretch receptors. When they are activated, when they are stretched too much, when they are going to stretch, they are going to stretch whenever there is high blood flow, high pressure, right? But there is no pressure, so they won't be activated. And we know baro, B for baro, B for brakes. Baroreceptors, they act as a brake to the BP. The function of the baroreceptor is to decrease the BP, right? But since we occluded the common carotid artery, no blood supply is reaching towards the baroreceptor. So baroreceptors are not getting stretched. If they are not stretched, that means they won't be causing decrease in the BP. Rather, there will be no stimulation to the VMC. So what they do, baroreceptors, there are two things. First is the VMC, that is vasomotor center, they usually inhibited, and the cardiac inhibitory center, we can say it as cardiovagal center, they usually stimulated. But since we are saying that they are not activating, since we occluded the artery, that means there will be no inhibition of VMC, there will be no stimulation of CIC, right? Vasomotor center will be activated, and if the vasomotor center is activated, the BP and as well as the heart rate, both the things are going to increase. Yes, please. Yes, I got some answers. Increase in the blood pressure and increase in the heart rate. Yes, option C is correct answer. Why? Because we haven't allowed the baroreceptor to work or decrease the BP and heart rate. That's true. All right. Even if you forgot the physiology completely, at least please remember what we are discussing here. Drug of choice, okay? You'll be able to recall it whenever you're going to see the MCQs. Don't worry. Right. Let's move on. In the cardiovascular system, at which of the following site does the blood flow lose the greatest amount of energy? Yes, please. There are different types of vessels. Now, please remember, Wind-Kessel vessel, they have elasticity property. So, they are the elastic arteries and aorta, right? So, they are helpful to maintain the diastolic blood pressure, right? Especially the aorta. Exchange vessel, they are very thin vessels, right? They are very permeable vessels. So, they are nothing but the capillaries. Exchange is their function. They are very permeable. That is their property. Capacitance vessel, they have capacity to stretch, but they do not have that much of the elastance. They are having good compliance, poor recoil, right? So they are nothing but the veins, systemic veins. Conduit vessels, what are the conduit vessels? Yes, I got the answers right. Conduit vessels are the smaller arteries, they are going to be the conduit vessels as well as the bigger veins. Okay, now understand, resistance vessel, whomsoever is going to have maximum smooth muscle, they are going to constrict the blood flow and going to give maximum resistance. To overcome the resistance, we have to apply the energy, right? So that means this is nothing but where the maximum amount of energy is going to be required to overcome that constriction force, and that is nothing but the arterioles, right? The valve doesn't have any role per se, right? It depends on the pressure gradient. Okay, I hope we discussed this right. Let's move on to the next question. I got all the answers right of this question, so let's move on. Mild hypovolemic condition, body still maintain adequate perfusion of vital organ. Most effective parameter, decreased to the decreased blood flow to the tissue bed from the following option. Yes, please. How it is going to maintain? What they are asking is, what is the main parameter which is important? Remember, flow is equal to pressure upon resistance. Usually we say delta P by R. According to Poiseuille-Higgins law, R is equal to 8 eta L upon pi R raised to 4, isn't it? This is the Poiseuille-Higgins law. Put the R into the flow formula. That is going to be delta P pi R raised to 4 upon 8 eta L. Poiseuille-Higgins law. Now understand, the length is there which is inversely proportional, right? And the eta, what is eta? It is going to be the density it is going to be the density, right? The rho is density, which is applied in the Reynolds formula. Over here it is going to be the viscosity. R is having fourth power, so the radius is going to be the most important factor. Why? Because let's say the radius, we double up the radius. If the radius R is 1, then the flow is going to be, let's say, 1. Okay, when we increase the radius to the double, what is going to happen? It is 1 raised to 4 is equal to 4, 2 raised to 4 is equal to 16. That means the flow is going to increase 16th time. Okay, so what is going to happen over here? Venous pressure, arteriolar pressure, viscosity or the diameter of the vessel. The pressure, yes, it is important, but it is proportionate. But remember, whenever we are going to talk about the diameter, it is the double of the radius and it is having fourth power. So definitely the most important factor over here is going to be the diameter. Yes, all of you gave the correct answer. Let's move on to the next question. Left and right ventricular chamber works for systemic and pulmonary circulation respectively. Which of the following characteristic is most similar in the systemic and pulmonary circulation? All right. How can the axon alone can damage the intact covering? If there is any internal injury, why isn't it possible? It is definitely possible. Tom Cruise. Yes. If there is any internal injury, definitely, if there is any metabolic issues, if there is any activation of, let's say, any other infection is there or any damage causing enzymes are activated, definitely there are going to be axotomasis. All right, coming to the CVS. I'm getting the right answers over here. Please remember. Okay, B, A, work done. About the work done, please remember over here what happens in the systemic and pulmonary circulation. Pulmonary circulation, that means from right ventricle to the pulmonary and towards the heart back. Now understand, the heart is very close to the lungs, so it doesn't have to put that much of the effort. But when we talk in terms of systemic circulation, left ventricle, it has to push the blood from the tip of your head towards the tip of your toe, right? So it has to put the more efforts, right? It has to apply more force. So that means work done of the systemic circulation, that means work done of the left ventricle is going to be much more. And that's why the thickness of the left ventricle is 3 times more as compared to the right ventricle, right? So that means the work done cannot be similar. Preload. About the preload, suppose 5 liter is the venous return. The same 5 liter is going to come into the right ventricle. Same 5 liters will go into the, you can say, the lungs. And same 5 liters will come into the left ventricle per minute. And the same 5 liter of the cardiac output will be given to the body. That means, yes, the preload is going to be the similar thing in the pulmonary and systemic circulation. What about the afterload? Afterload, that means after the, let's say, right ventricle and left ventricle, after over here, how much resistance, against how much resistance the right ventricle has to work, that is the afterload for the right ventricle. Against how much resistance the left ventricle has to work? That is the afterload of the left ventricle. So please remember, we just now discussed that the afterload of the left ventricle is going to be much more. Why? Because the whole system is going to give much more resistance as compared to the lungs alone, right? So definitely the afterload of left ventricle is going to be much more as compared to the right ventricle. Peak systolic pressure, we know that the peak systolic pressure of the left ventricle is around 120 mmHg in the normal person, and it is going to be around 25 mmHg in case of right ventricle. So they are also different. So the answer over here is option B. Yes, Sarika, it is not D, dear. It is going to be 120 and 25 in the right ventricle, left ventricle respectively. It is going to be 120 mmHg, and right ventricle it is going to be 25. There is a huge difference. It is not similar. Okay, let's move on to the next question. Using fMRI, that is functional MRI, scientists were studying the blood flow to the brain during the exercise. Which of the following is true regarding the physiological changes in the brain during the moderate exercise? Blood flow is decreased. Now understand, they're asking about brain. Blood flow is increased, blood flow remains unaltered. Blood flow initially increases, then decreases by physical representation. Yes, please. During the exercise, what is going to happen to your brain and its blood flow? Okay, Dr. T has changed his answer. I hope it is his. Okay, that's true. It is unaltered. Why? Because the brain and the heart both show best autoregulation. Both shows best autoregulation. No matter what is going to happen, they are going to maintain their blood flow constant. Okay, so that is going to be, it is kind of a tricky question, right? So they want to know whether you know the funda of autoregulation or not, right? Yes, it is not unaltered. It is not A, not B, right? It is not going to increase. Otherwise, what will happen over there? If you're increasing your brain blood supply unnecessarily, what is going to happen? The hydrostatic pressure inside will increase, and there will be cerebral edema, which will not take place. Please remember, it is unaltered. During the exercise, it is unaltered. If there is a hypoxia, temporarily the vasodilation will occur, right? But it will maintain its blood flow. Okay. It is going to maintain its blood flow. Now, the question they can ask is, the autoregulation is absent in. Remember, the autoregulation is absent in pulmonary system as well as skin. Pulmonary system and skin. Okay. Whatever blood is coming from the right ventricle, the lungs has to take it, right? There is no option. So there is no autoregulation in the pulmonary system. In the skin also, there is no autoregulation. Okay. And that's why for the heat conservation as well as heat loss, we use the vessels below it, beneath the skin. Okay. Let's move on to the next question. Which of the following statement is incorrect? An isovolumetric ventricular contraction. The AV valves are closed while the SL valves are open. First heart sound occur after isovolumetric contraction phase of the cardiac cycle. Pregnant female, third heart sound can be heard during early ventricular contraction phase of cardiac cycle. Isovolumetric ventricular relaxation is also called as diastole proper. Incorrect except. That means we have to find out correct option. Yes, please. First of all, they asked about the sounds, right? So please remember S1, S2, S3, S4. 1, the first alphabet is A, right? So AV valve closure. When the valve closes, they make sounds. Like doors, right? When the door closes, they make sound. When they're opening, they won't make any sound. So closure of AV valve will make S1 sound. First alphabet is A. Second, S for second, S for semilunar valves. When they close, they make this S2 sound. S3 and S4 both comes during filling. If it is early filling, we are going to get S3 sound. If it is late filling, we are going to get the S4 sound. Both of them, in the normal cases, they are below 20 hertz, so the normal person cannot hear it with the naked ears, right? So definitely they are not heard, but yes, during the pregnancy they are heard. So in the pregnant, third heart sound can be heard during early ventricular contraction. If they would have given it as early ventricular filling, that would have been correct. But over there they gave the contraction. Contraction is not right, guys. It is not the option C. Yes, I'll be discussing that also later on. Don't worry. First heart sound occurs after isovolumetric contraction phase of the cardiac sound. No, isovolumetric, no valve will open, no valve will close. In the iso, the both valves are closed. They are not closing, they are already closed, and then only the isovolumetric will start. So this is also not correct. An isovolumetric ventricular contraction, AV valves are closed, SL valves are open. ISO में both the valves are closed, be it the isovolumetric contraction, be it the isovolumetric relaxation. Okay, isovolumetric ventricular relaxation is also called as diastole proper. That's true. That's true. Okay, we say protodiastole, right? What is the protodiastole? When in the diastole, what is going to happen? The ejection is over. Now the SL valve will close. There is a small phase just before the valve closure in which there is no momentum of the blood towards the aorta. Aortic pressures are balanced now, and the SL valve will close in some time, right? So that phase, at that phase only, the ventricles start relaxing. When the ventricles start relaxing, but over here the diastole hasn't started, the SL valves are not closed, and this is known as protodiastole. Okay, and when the valves, SL valves are closed and then the ventricles start relaxing, that is known as diastole proper. IVR is known as diastole proper. Over here the correct answer is D, not C, since the S3 sound doesn't come in the contraction phase. It is during the filling phase of the ventricle and not during the contraction. Let's move on. All of the following are true except, okay, the RESPI and CVS is over. Now two topics are left. Please give your 100% over here. We are about to finish. We are halfway. More than half is done, right? All of the following are true except BER arises from interstitial cells of Cajal. That's true. It is the pacemaker. That's true. Maximum motility is found in sigmoid colon. Is it true or not? Acetylcholine causes increase in the muscle tension while epinephrine causes decrease in the muscle tension in the GIT. BR usually causes muscle contraction independently. True except, that means we have to find out false. False. Now understand, maximum motility is found in sigmoid colon. That is also true, right? The acetylcholine causes increase in the muscle tension. I hope I have, okay, diagram if I draw over here. So let's say if this is the BER. What is the BER? BER is nothing but the basal electrical rhythm. Basal electrical rhythm is present in the smooth muscles of GIT. Now understand, whenever I'm going to pour the acetylcholine is a parasympathetic. Parasympathetic system itself is called as rest and digest system. So that means the digestion or the GIT is stimulated by the acetylcholine. So what is going to happen? The tension, if I measure, so that is going to increase. The tension in this is going to increase as soon as I keep the acetylcholine. Suppose if I keep over here, the epinephrine is poured into it. What is going to happen to the tension? The tension is decreased. These are the RMPs and not the action potential, right? So what is going to happen if I stimulate it? If I give the stimulus, suppose this is the minus 60 and over here it is minus 40 MV. It is the RMP. Please remember that. It is the cyclic fluctuating RMP and not the action potential. For the action potential to occur, we have to give the stimulus. Whenever we are going to give the stimulus, what is going to happen? Let's see. If I'm giving the stimulus over here, so there are going to be some spike potentials which are going to be generated. These are the action potentials. Okay, they have asked in the INICT last year, that is calcium entry causes depolarization and potassium efflux causes repolarization, right? They have asked about the repolarization of the spike potential in the GIT, so please remember this. All right, now over here acetylcholine, this is also true, right? And the pacemaker, it is also true. So BR causes muscle contraction independently, that means you do not require any stimulus. If that would have been the case, our GIT must have contracting all the time, which doesn't occur, right? We need the stimulus for it. Stimulus can be, most common stimulus is food bolus, it can be barium, it can be calcium, it can be sympathetic activation. Okay, so the stimulus is required over here. The sympathetic causes the inhibition of it, and parasympathetic causes the stimulus. Okay, so parasympathetic, be it the barium, be it the calcium, right? All these things act as a stimulus. The most common is food bolus. Most common is food bolus. Okay, so all these things are going to act as a stimulus, right? Let's move on to the next thing. BER is maximum in the duodenum. I agree with you, but that is not the spike potential, dear. They are asking about the motility. Motility is different than BER. BER is basal electrical rhythm. It's a RMP. It doesn't have direct correlation with the contractility. Please remember that. Contractility is different. Okay, I hope it is clear. BER is Pratik. BR is different. It is the RMP. It has no correlation with the motility. Okay, the concentration of calcium channel is more in the sigmoid, and the motility is maximum there only, right? BR is RMP. Again, I'm telling you that that is not the contraction. Next question. 68-year-old woman, hematemesis, has heartburn, stomach pain, endoscopy shown inflammation involving gastric body antrum as well as H. pylori, damages gastric mucosa primarily by increasing mucus levels. All right, 1 minute, मैंने डायग्राम्स डाले थे, नहीं है इसमें. Ammonium, let's go. H. pylori, what the H. pylori will do, it is going to have urease enzyme in this. Okay, so urease, what it is going to cause? It is going to cause the production of ammonia, which is going to give the feel as if to the parietal cell. Suppose the H. pylori comes over here, it is going to break down the urea and produce a lot of ammonia, and it produces the alkaline medium over here, right? It is going to bind to the H plus ion. H plus ion is not free, so it will create the alkaline kind of a medium around the parietal cells. So the parietal cells will not be able to sense that acidity is present. It's just not present at that area, right? So the diagrams are not there. I hope I would have shown you, but anyways, so what is going to happen because of this alkaline like feel, the parietal cells start secreting more and more H plus ion, and the barrier will be eaten up by these H. pyloris, right? So that's why they are going to generate what thing? The gastric ulcers. So the levels, the gastric mucosa, H. pylori, yes, the gastrin levels, it can cause the ulcers, but remember it is not having a correlation with the H. pylori. NSAIDs also causes the gastric ulcers, but not because of the H. pylori, right? So they're the drugs. So the best option over here is going to be the ammonium, okay? Right, to make it alkaline. Good. Let's move on to the next question. A 32-year-old female came to the OPD for follow-up, vitamin B12. Okay, which of develops post-gastrectomy? Vitamin B12 deficiency anemia is there, right? Post-gastrectomy, and intrinsic factors protect the vitamin B12 from the degradation in. Yes, please. Answers. Answers. Option B, C, A. Okay. B, C, A. Alright, chalo, let's discuss vitamin B12. Suppose I had the vitamin B12. Now, what is going to happen? Vitamin B12 is very delicate kind of a vitamin. It needs protection all the time, like Papa Ki Pari, right? So, what is going to happen? From the salivary gland, the heptocorin will be released to protect the vitamin B12, right? So, heptocorin is going to bind to the vitamin B12, right? Because we have to protect it from the enzymes, as well as this combination will come as soon as it is going to come into the stomach. What is going to happen? Lot of acid is there, so it is going to protect it from the acid also. Now remember, the intrinsic factor is released from the stomach, but what is going to happen? The heptocorin is still attached to the vitamin B12. At a time, only one thing can cover the vitamin B12, not both the things, right? So over here, the heptocorin is still protecting the vitamin B12. Now the intrinsic factor is released by the parietal cell, but understand it is not binding to the vitamin B12 over here. It is going to come to the small intestine. D2 area, we are going to have ampulla vata, which is going to secrete all these pancreatic juices, as well as from upside we are going to have the common bile duct, which is coming, which is going to open up right in the D2 area. Now understand, the pancreas also release the pancreatic peptides or peptidases, right? What they are going to do is they are going to break away this heptocorin from vitamin B12. Now the vitamin B12 is free. Over here, the vitamin B12 will be free as soon as the pancreas break the vitamin B12. It's separated from heptocorin because of this peptidases, right? Now what is going to happen? This vitamin B12 will be bound to intrinsic factor. So please remember, the intrinsic factor is going to protect the vitamin B12 in the small as well as the large intestine, right? Not in the stomach, okay? It is not going to protect in the stomach per se, okay? In the colon, we are going to have some bacteria which are helping us to produce the vitamin B12 and various vitamins like vitamin K itself, right? And if I ask you where the vitamin B12 is reabsorbed, vitamin B12 is reabsorbed in the end of the ileum, that is terminal ileum, which is the end part of the small intestine. So whatever a dietary intake we are having, so that is going to go till the terminal ileum only. So the best answer over here is small intestine, right? So the best answer over here, it is going to protect the vitamin B12 from the degradation in. So that's why please solve at least some MCQ, few MCQ every day, because you know the questions, you know the answer, but silly mistakes, right? Which we have to avoid these days. All right. Look over here, that was the diagram which I wanted to show you for the H. pylori. Urease is there, which is going to create the environment, alkaline environment, as well as it is going to cause the mucosal damage over here, right? Let's move on. Okay, so I feel like most of you are feeling like this. I need something that is more than the coffee but less than cocaine, right? Yes, we are halfway there. Let's move on. All right. Okay, no issues. Whatever answers you're doing wrong over here, that's okay, but do not repeat the mistakes in the exam. That's our only goal, okay? The migrating motor complexes, MMC, which is also called as hunger pangs in the layman term, right? Pet mein chuhe dodna, right? So that is going to be true about. That's what we have to see over here. Occurs only in the small intestine. Understand, it starts from the stomach. It goes till the colon, or I can write intestine, right? So it is not only going to occur in the small intestine, that is wrong. Requires intact intrinsic nervous system for coordinated propagation, that's true. Is a result of food mediated distension. It is the hunger pang which is going to occur in interdigestive period. And 1 mmc is for 90 to 110 minutes. Please remember this is asked too. Okay, mixes intestinal contents with the bile. There is nothing in the intestine, right? And that's why the rats are running there. So please understand, there is nothing in the intestine, which is why we are having hunger pangs, right? So mmc is hunger pangs. So only correct answer over here is option B, right? Everyone got the right answer. Okay, so the diagrams have been shifted here and there. I don't know how, but this I wanted to show you. Heptocorin from the vitamin B12 is going to protect it here, and then it will protect it in the stomach also. The intrinsic factor, though it is released over here, but it won't be able to protect the vitamin B12 here unless and until the pancreatic proteases, they are going to break away the heptocorin, and then only the this intrinsic factor is going to bind to the vitamin B12, which will be protecting it throughout the small intestine, and it will be, the B12 will be absorbed in the terminal ileum. Next question, most common cause of iron deficiency anemia, lack of dietary intake. Okay, iron is transported from enterocyte to the capillary through. Okay, so there are two areas. So suppose this is the cell, okay, and this is the capillary. So this is going to be the basal side, and this is going to be the apical side. Yes, please carefully read the question. Transported from the enterocyte to capillary, that means they're asking us about the basal area and not the apical one. Okay, I'm getting the answers B. I want you to recheck again. Yes, see over here, the diagram is shown. Now look over here, the DMT1, first thing first, DMT2 is not helping us anywhere. DMT1 is going to help us, dimetallotransferase 1, but it is present on the apical side. It is going to help us to reabsorb or absorb the iron from the lumen into the cell, not from the cell into the capillary. So please mind that. Okay, so over here the iron is going to get reabsorbed via DMT1, but on the basal side we are going to have ferroportin, and to help that ferroportin we do have the hephaestin there, right, which will convert the Fe3 plus into Fe2 plus, so that it can come into the, or it can cross the membrane. Okay, so that is the case over here. Please do not make the mistake. The question is different. Okay, see the question again. It is asking us about the enterocyte to the capillary. Yes, please. Yes, now I got the right answers. That is ferroportin. Very easy question, just the tricky questions. Okay, 52-year-old male come to OPD with complaint of weight loss despite of overeating, continuous thirst sensations, increased urinary frequency. Physician advise investigation. Which one of the following? Acha, okay. Glucose is absorbed in the intestine by. It's a very easy question. Again, we do have basal side and apical side, right? This is the apical side from which the SGLT is going to act, right? And over here the glut will be acting, right? Especially the SGLT1 and the glut. Over here the glut will be 2. Okay, glut2 will be reabsorbing the glucose, right? So they haven't asked us about anything about capillary and all, so it is in the intestine. So I'll go with the secondary active transport. Every one of you, you're correct, not the facilitated one. They haven't asked us from the intestine, right? Yeah, the NB checking, it seems like our the knowledge of English rather than knowledge of medicine, right? So if nothing is given, go for the apical ones. That is important since they are asking in the intestine. Okay, that means in the enterocyte basically, right? Okay, let's move on. Which one of the following does not have a sodium iodide transporter? Does not have sodium iodide transporter. Yes, please. Remember, in the thyroid we know right? In the placenta also it is there. In the salivary gland it is also there. It's a factual question, purely factual question. In the pituitary gland, what will we do with the iodine, right? We do not want iodine for anything in the pituitary, right? So that's why we do not have the sodium iodide transporter in the pituitary gland. Okay, yes. Babita Gupta, I got the right answer from Babita and Sarika, right? Sarika. Santi Barman. Okay, I hope you're giving the answer for the question of sodium iodide transporter, right? Please recheck. So yes, we need the sodium iodide transporter in the salivary gland to absorb it. Okay, but there is no use of it in the pituitary gland. What it will do there, right? So this is the sodium iodide transporter in the thyroid gland. On the other side, towards the colloid, we are going to have pentrin protein, which will transport the iodide in and make the chloride to go out. Okay. Let's move on to the next question. The hypothalamus and fat tissues also play important role in the regulation of energy metabolism. Leptin acts by increasing the activity of. They're asking increasing the activity. Yes, give me the answers. Till that, I'm going to give you a mnemonic. A, B, A. Okay. All right. So please remember this mango. As soon as you see mango, most of you must be liking this fruit, right? So the hunger is increased. So the appetite is going to increase in this case of mango. On the other hand, the leptin, what it does, it is the anti-obesity hormone released from the fat tissue or adipocytes, right? What it is going to do, it is going to stimulate the melanin stimulating hormone, not the concentrating hormone. It is going to stimulate the alpha MSH, which is released by the pomp neuron, that is pre-opiomelanocortin neurons. Now understand, it will inhibit the hunger center and it will stimulate the satiety center, the hunger center, that is paraventricular nucleus. It is going to be inhibiting that which will cause the food intake, right? If it is inhibiting, there will be satiety, there will be no hunger. On the other hand, the leptin is going to inhibit the AGRP as well as neuropeptide Y. Please remember that. Okay. And if the leptin is having defect, the person will not feel the satiety, right? And the familial obesity is going to be occurring in that patient. So please remember, leptin stimulates. What they're asking, act by increasing, that means stimulating. The answer should be alpha MSH and not the HRP or neuropeptide Y. Okay. Yes, RK, Sarika, all of you are right. All right, let's move on. Ghrelin is increasing the hunger and leptin has no effect on the ghrelin. Please remember that. Okay. Mango increases appetite, on the other hand, alpha MSH decreases it. Next, during the dark phase, the interesting topic has come. During the dark phase of visual cycle, which one of the following from the vitamin A combines with opsin to make rhodopsin? Volt cycle or visual cycle? Yes, please answer. Alright, Dr. Rao and real guy. Okay, I got the answer for this or the previous one. D and B. Alright. In the dark phase, what is going to happen? The retinal is present. Which retinal is present with the opsin? Remember, please, C comes first. That is 11 cis retinal is present, which will be converting via the isomerase. As soon as light falls on the rods and cones, isomerase will be active. The isomerase causes conversion of all 11 cis into all trans retinal, right? And that will stimulate trans retinal is there, so that is going to stimulate something known as transducin. Transducin will cause the activation of phosphodiesterase that will break down the cyclic GMP into 5-GMP. That will causes the closure of sodium channel and the cell will be hyperpolarized. Closure of sodium will causes hyperpolarization. Yes, you all are right. It's the 11 cis retinol. Remember, this is the special thing about this special sense, that it causes the hyperpolarization during the after giving the stimulus, right? Everywhere when you give stimulus, the cells are usually depolarized. This is the exception of the vision, that the rods and cones are actually hyperpolarized. Nowadays they are giving the graphs also. Please remember, if the graph is shown like this and hyperpolarization is given, and they ask you to identify which type of receptors they are there, so that is nothing but the rods and cones. Okay, if there is a hyperpolarization, they are going to be rods and cones. Next, okay, rock concert was there. 20-year-old student notices difficulty in hearing. All right, lecture में तो सभी को problem होती है. The physician at students' health center suspect possible damage of his hair cells by loud music. Depolarization of the hair cells in the cochlea. First of all, the hair cells are present in the scala media. And the scala media is going to have something known as stria vascularis. This is the special thing about this special sense, that whenever there is a depolarization, what is going to happen in the hair cells, we do have cilia which are attached with the tipplings. As soon as there is movement of these cilia, especially the stereocilium towards the kinocilium, which is the tallest one, the entry of the potassium occurs. Why? Because the stria vascularis continuously secreting the potassium over here, and that is known as endolymphatic potential. The question has been coming on this endolymphatic potential a lot of times, so please remember this, endolymphatic potentials. Okay, all of you are correct. That is the potassium into the hair cells because of the stria vascularis. All right, a patient came to emergency department after bike accident, lying down supine on the stretcher. Right, he is lying down supine. I don't know what type of patient he was. Attending doctor advised few imaging investigation. Ward boys took him through the lift on the stretcher. If the patient's senses of equilibrium is intact, which one of the following sense organ will be activated? Yes, please answer. Answer over here will be what thing? First thing, we should be knowing that whether it is horizontal or it is vertical. For the ward boys who are standing, the lift is going up, right? So for them it is the vertical acceleration. But understand, he is lying down supine and he is going front, right? He is lying on the stretcher, so he is going up. So that means it is going to be front for him. So please understand, it is going to be the horizontal acceleration. So please remember, the semicircular canal causes vertical. On the other hand, the utricles are activated whenever there is the horizontal activation or horizontal acceleration. So for him, it is going to be the horizontal one since he is lying down. So the appropriate answer over here is option A. It's not B, it's A. They haven't asked it for the ward boys, right? They're asking it for the patient. The patient is lying down supine. Please remember that. Very tricky question though. Let's move on to the next question. I hope when you got the answers, who got it wrong, they must have think like this, right? So actually they are checking your smartness at that point also. But we have to pass, right? So let's go through. 57-year-old patient recovers from COVID-19 infection but still complains of no improvement in the smell and taste sensation. Bitter taste is mediated by, right? COVID-19. Oh my god. Okay, we cannot miss that question. Now, just understand there are two types of mediators. First is ionotropic mediation and metabotropic. I'll give you a simple mnemonic. Metabotropic means which is acting through GPCR proteins. We're not going to go in the detail of which ion, how that occurs, right? That will cover in the lectures. But please remember, salt and sour, these two test sensation, they are having four alphabets. So please remember, if I'm going to ask about inotropic, only these two are inotropic, and rest all which are having more than four alphabets or letters, that is the sweet, bitter and umami, right? All of them are going to act through the GPCR protein and they are going to be the metabotropic, right? Over here we are talking in terms of inotropic, right? So they are asking bitter, that is going to come in the metabotropic. If they would have asked about salt and sour, that would have been inotropic. We are talking about GPCR protein, so that is not in the option, but the G protein is nothing but the GPCR that we are talking over here, right? So the answer is B. Yes, all of you. Right. So please open up your mind whenever you are going to the exam. Have sips of coffee, right? All right. In diagram given below, what is A and B? Very easiest question. Hanji, answer please. Easiest question. All right, I'm getting the answers. Umami. Umami is a type of taste. What type of taste, I cannot explain you how it feels, right? But if you go to the KFC, if you are non-vegetarian, so if you go to the KFC or you have that oregano, which is acting as a toppings on the pizza, on the you can say pizza or wherever, we use oregano. That is nothing but Ajinomoto. We use it as Ajinomoto, which is having monosodium glutamate. If you taste that, it is having a combinations of taste. It is a different type of taste. That is nothing but the umami taste. Please remember that. Okay, Pratik. Fine. All of you gave me the answer correct. So they are asking about the exoplasmic transport over here. Exoplasmic, if it is going towards the terminal, it is going to be the kinesin. And if it is coming back towards the body, it is the dynein. How to remember dynein? If a person dies because of the viruses or like rabies or herpes, or we can say there are many, tetanus, herpes, rabies, right? What happens as soon as these viruses come in our body, and if they find out a empty vesicle, with the empty vesicle and with that dynein, what they do is they are going to go towards the body and they infect, they proliferate and they cause infection. That's the reason the person can die, right? Who is the reason? Dynein. So please remember kinesin and dynein. Dynein causes retrograde transport. Anterograde or orthograde is because of the kinesin. Let's move on to the next question. Skin. Somatosensory receptor works as transducer, convert various types of sensation into electrical energy, since our brain doesn't understand other languages, right? And send the signals to the brain. One of them on onion-shaped corpuscle present in the dermis. Yes, please answer. Who is onion-shaped? Polio also. Yes. Anamika, right. Polio also works through the dynein. All right. Look over here. These are Merker's disc. You can see smaller disc which is also capsulated. These are Ruffini endings which senses mechanical sense or mechanoreceptor which sense the stretch also. Right over here, these are Meissner corpuscle. Whomsoever starting with MM, they are for fine touch and they are for 2-point discrimination. Both causes 2-point discrimination, but better with the Merker's disc because they are having smaller receptive fields. Okay, so better will be the 2-point discrimination. Receptive field is smaller as compared to the Meissner's corpuscles. Okay, if they ask about density, it is going to be the Meissner's corpuscle who are going to have more density. Then Merkels are also better in the 2-point discrimination because it can detect the edges, right? So that's why edges, pointy things. So that's why it is better. Now in the deep dermis, these all are going to have with the Krauss bulb. They are going to be present in the all of that. They are going to be present in the superficial dermis. But remember, there is one corpuscle which is present deep inside. If you have to stimulate who is deep inside, we have to apply pressure. It cannot be activated by fine touch or crude touch, right? And it looks as if we cut the onion. I don't know why the examiners are fond of onion shape. They are behind this onion shape, right? So please remember, they are indirectly asking about Pacinian. Pacinian causes two things or sense two things. First is high frequency vibration, and second is P for Pacinian, P for pressure. It's not pain, please remember that. It's the pressure, okay? Yes. D-ish, right. Braille reading, Merkel's disc. That is also true. So over here, the answer is very simple. You just have to know about Pacinian corpuscles, right? That they are onion shape. Okay. The pain is sensed by free nerve endings. And they are non-adapting. Whomsoever saying, "Mat ko dard nahi hota," please do the checkups because the dard is very important. It's the protective phenomena, right? Only person cannot have pain who is having leprosy, right? So do not use the Bollywood terms. Let's move on to the next question. 32-year-old male patient comes to the OPD with the complaint of diffuse pain in the abdomen from last 3 hours. Tells attending physician, okay, ate street food last night. Please do not eat street food until the exams are done. Sensations. The sensation is transmitted by, yes please. Sensations are transmitted by. Alright, so there are two types of pain, fast pain and slow pain. Pain zaruri hai bhai, zaruri hai, right? So fast pain, slow pain. Fast pain is carried by A delta and slow is carried by C. A delta, it is going to be very sharp, well localized and pricking type of pain. Sharp, well localized, pricking type of pain. Epicritic pain, protopathic pain, right? Protopathic is slow one. It is going to be dull and diffuse, right? So whenever exact localization was mosquito bites you, right, you know exactly without even looking at it, you can just slam your other hand, right? So that is means your brain is able to localize it. But if the patient comes of, let's say, liver cirrhosis, he doesn't know exactly which hepatocyte is having or causing the pain, right? Especially the visceral pain, right? That is going to be the slow pain because the viscera, they do not have the free nerve endings, rather their coverings are having the free nerve ending. That was the also question which has been already came in the exam. So over here, it is going to be the C fibers. Every one of you are right, absolutely correct. Let's move on. The distance by which two touch stimuli must be separated. That is 2-point discrimination greatest at. Yes, please, answers. It is going to be greatest at. We'll ask after the exams that who got the greatest marks, and I want the answer to be cerebellum students. Right. All right. Okay. Read the questions carefully, guys. Read the questions carefully. NM, NB people are not fool. They're making us fool. Don't allow them, please. You're giving me the answer as A. They are separated by the distance by which two touch stimuli must be separated to be perceived as two separate stimuli is greatest at. It cannot be lips, guys. It cannot be lips. The distance in the lips and fingertips, it is minimum. The 2-point discrimination, if they would have clearly asked 2-point discrimination. Yes, now you guys are right. Why this is showing discrimination? Right. Discrimination is best at lips and fingertips because of our evolution, right? But remember, the distance over here is minimum. They're asking about the distance by which two blah blah blah. Then they ask as two separate stimuli greatest at. That means they're asking where the distance is greatest. That is going to be, yes, now you guys are right. Okay, Aditya Kumar, again check your answer, please. The distance is not rated as lip, it is the least at these two places. So if they ask about the distance, it is going to be the least distance, not the maximum. Silly mistake. Avoid those. Please avoid those. And that's why we are having PYQs, right? It was very short notice. But it is worth it. If you even make, 4 or 5 silly mistake, avoid those silly mistake and make the correct answers in the exams, okay? It's okay to do the mistakes over here, but not in the exams. Which of the following is false except? Yes, please. 1A afferent fiber supplies to nuclear back fiber. This came in the INICET in the 2021 or in the beginning of 2022. It got postponed, I guess. So please tell me the answer. Okay. Chain fibers and back fibers. I hope you can see this. Chain fibers and let's say back fibers. Now understand the chain fibers, they are static ones. Why they are static ones? Because they can sense the initial and final length, how it is changed, right? How much it is changed rather. But the back fibers, they are going to have the nuclei in all directions, so they can sense both static and dynamic. So they are going to sense the length also, velocity also, momentum also, and that's why they are known as dynamic. Now understand, when we talk in terms of 1A fibers, they are annulospiral fibers, right? Annulospiral fibers, they are providing the supply to the back fibers only. That means we have to understand that which one is the true of these, right? They are saying only to the back fibers. Now understand, annulospiral fibers, they are present in between the muscle fiber. That means they are providing both. The static fiber be true. It is false indeed. Two afferent fibers have their secondary endings to nuclear back fibers. Now understand, two fibers, type 2 fibers, they provide their endings to the static only because they are present at the end, and towards the ending the back fibers will not be there. The back fibers will be in the middle, okay? In the ends we are going to have the chain fibers, and that's why the two fibers cannot go there. They are flower spray endings and they only supplies the chain fibers. So this is also false. Static response carried by both bag and chain fiber. Now that is true. Static are sensed by this, and I told you the dynamic fibers are said so because they sense dynamic mainly. But understand, they can sense the static too, right? Isn't it? Dynamic response carried by both bag and chain fiber. No, the chain fiber cannot sense this dynamic response. It is only for the static. But remember, the dynamic can sense both the things. So this is right. INICET usually do not check our grammars and all, but yes, it makes everything so complicated, right? So you just have to have the presence of mind, nothing else. Okay. So this type of question can come in the NEET too. So please remember the correct answer over here is C. Yes, Kishore Kumar, I got the right answer from you. Dr. Shankar, real guy. Okay, I got the right answers from you. Option C is correct. Okay. Dynamic fiber, they can sense the static also, dynamic also, static only static. Or the type 2, that is flower spray ending, only to the static, right? Not to the back fibers, not to the back fibers, only to the static. So please remember these things. All right, let's move on. 32-year male was working in the factory, came to the emergency, neurological deficit. Okay, paragraph question. In this anomaly, patient symptoms, physician suspecting syndrome where hemisection of the spinal cord occurs. In this abnormality, which of the following occurs in the level of the lesion? Hanji, please tell me. At the level of lesion, what is going to happen, guys? Below, what is going to happen? Above, what is going to happen? Now they know that you know it is the Brown Sequard syndrome. They won't be asking you the name of it, right? Rather, they will be asking about at that level what is going to happen, above that what is happening, below that what is happening. Now understand, if I say at this lesion, what is hemisection is cutting off half of the spinal cord. Usually what happens, the fibers enter in the spinal cord, especially the lateral, anterolateral tract. Either they will cross over at the same level or they go one or two levels up above, right? And then they cross over. Okay. So one or two levels above, and then from here they will cross over and go up. Still they will be in the spinal cord. Okay. At the same level or 2 to 3 segments above. On the other hand, when we talk in terms of dorsal column, what will happen in the case of dorsal column? Suppose this is the dorsal column. Dorsal column will go up till the medulla, and from the medulla it is going to cross over. Okay. So the dorsal column won't be crossing over. So that means it is sure that if I cut this section over here, what is going to happen? Now understand, at the same section, what is going to happen? The another anterolateral tract must be coming from here, and either it is going above 1 to 2 segment or it is crossing over. But even if it is crossing over, what is going to happen? See over here. Suppose this is coming anterolateral tract, which is coming inside. At that level, both the things will be gone, right? Same side anterolateral tract and same side dorsal column will be lost. Understand that. I'm asking about the same side. At that level, what is going to happen? At the level of lesion, both the tracts will be gone at the same side. Both tracts will be gone on the same side. Lesion will be on the same side. That means anterolateral also, dorsal also, right? So the pain and temperature is carried by the anterolateral, right? And the crude touch by anterior, especially. So the lateral, contralateral will not be there at the same site. Yes, if I talk in terms of below the lesion, what is going to happen? In that terms, definitely the anterolateral tract already has been crossed, so there will be contralateral loss of pain and temperature, but they are asking about the same level. At the same level, that will not happen. Below it will, uh, below it, below that lesion will be the loss of pain and temperature on the opposite side. Okay, contralateral fine touch loss. Fine touch will never loss in the contralateral side. Please remember, it will be always carried by the dorsal column. Dorsal column to always lost. Below at the same level, it will be same side, ipsilateral. Human paralysis. Now understand, over here the spinal cord is gone. That means alpha and the gamma, that is the alpha motor neuron and gamma motor neuron are gone at that level. Their upper segment is normal. It is getting a proper inhibition and stimulation. So it is not the upper motor neuron paralysis, but the lower motor neuron paralysis, since the alpha motor neuron and the gamma motor neuron, they are lower motor neurons. Okay, above which everything is normal. They're asking about what is happening at the site, at that lesion. So at the lesion, everything will be, the sensations will be lost on the same side, and there will be lower motor neuron palsy. Okay, plus if I ask you about below the lesion, what is going to happen? Below the lesion, contralateral loss of pain and temperature, and please remember, it will act as a human paralysis. Over here it will be act as a human paralysis because above the segments, the track has been cut from there, right? But that is for the below the lesion. Okay, if they haven't mentioned anything or they mentioned below the lesion, then only you can write that. Okay, let's move on. Next question, the alpha rhythm appearing on the EEG, following characteristic. Alpha, let's write all the things. Bat dance. What is bat dance? Bat dance, that is nothing but the beta wave, alpha wave, theta wave, and D is for delta wave. Delta wave is from 0 to 3 hertz, from 4 I'm writing over here, from 4 to 7 theta, 8 to 13 alpha, and 14 to 30 will be beta, more than 30 will be gamma. Okay, usually for the meditation we need to close our eyes. So let's see, alpha wave 20 to 30 waves per second, that will be beta. It disappears when the patient's eyes are open. That's true, because visual stimulus causes the frequency of brain activity to increase, and that will create beta waves. Okay, that's true. Replaced by slower and larger waves during REM sleep. REM is a paradoxical sleep. Remember, they are faster and they are smaller, since the frequency is increasing, not the amplitude during the REM. During the REM, the frequency is increasing, amplitude is decreasing, right? It will be replaced by the beta wave during the REM sleep, and that's why it is known as alpha block phenomena. Okay, will be seen. It looks as if the beta waves are blocking the alpha waves during the REM sleep. That is known as alpha block. Anyways, but they are having the low amplitude and high frequency, so this is also wrong. Associated with deep sleep, D for deep sleep, D for delta waves, and not the alpha. Though some people go from the meditation into the deep sleep, but they will be having the change in the EEG waves also, right? So they will be having delta wave, right? So, but they are asking about the normal person, right? So it is also not true. In the deep sleep, we are going to have delta waves. Let's move on to the next question. Okay, we are done with the CNS. We are coming towards the endocrine. Hormone that uses this type of receptor in the image. Yes, please. Answer. Bat drink blood at night. Okay, fine. We can use that mnemonic too. Whatever feels easy to you. ज़्यादा टफ नहीं है यार, बिल्कुल टफ नहीं है. It's easy. Just open up your mind. It's easy. Sparrow. Yes, it is easy. No, it's not tough. At least you won't be repeating this same mistakes again in the exams, right? All right. Chalo, answers mil rahe hai mujhe. See over here, it is the cytoplasmin. They are not lipid soluble, right? Dopamine is monoamine, and non-adrenaline, it is also the catecholamine, right? So both of them are going to act through the cell surface receptor. Okay, they are not going to act through either cytoplasmic or nuclear receptor, right? So please remember that. Right. Let's move on to the next question. The answer is vitamin D. Let's move on. A 55-year-old man comes to his primary care clinician complaining erectile dysfunction. Prescription of Viagra is given. Reports that his ability to sustain erectile has been improved. Okay, the action vasoactive mediator act through which of the following secondary messenger? You must have studied that in the pharma also, right? Yes, please, answers, guys. Now understand what the Viagra is going to do. Vasoactive mediator, that means it is going to increase the NO. NO is nitric oxide, isn't it? It is going to increase the nitric oxide, and the nitric oxide and ANP, BNP, CNP, all they are acting through. Yes, please, wherever N is going to come, that is going to act through cyclic GMP. Please remember, it is the cyclic GMP. We are not doing any contraction relaxation there, right? So please understand, it won't be helping us into the IP3-DAG. IP3-DAG, they are usually the contractile ones like oxytocin, angiotensin 2, vasopressin. Especially when we talk in terms of vasopressin, it is the V1 receptor. Okay. So the answer over here about the nitric oxide, they are asking, again, integration is very important, right? So it is not the cyclic AMP but cyclic GMP, right? You guys are right, cyclic GMP, right? Tyrosine kinase, nowadays the tyrosine kinase questions are also coming, so please remember it is the insulin and growth factors like PDGF, for example, platelet derived growth factor, fibroblast growth factor, nerve growth factor. If they ask everything, they are going to be tyrosine kinase. There is another one which is cytokine kinase, that is activating the JAK and STAT pathway, that is going to be the JAK STAT pathway, Janus kinase, and signal transduction and activator of transcription. JAK STAT pathway, through that we are going to have two hormones, growth hormone and prolactin. And these two are known as twin hormones because their action is similar, and even both of these hormones are released from acidophilic cells of the anterior pituitary. So please remember, both of them are released from same type of cell, plus their action, the pathways are similar. That is nothing but the JAK STAT pathway, and that's why we are going to call them as twin hormone. Okay, we are going to call them as twin hormone. Let's move on to the next thing. Okay, identify the conditions shown in the following image. Okay, we have to identify what is X. Okay, so identify the X. Please identify the X. Okay. Erythropoietin also act via this cytokine. Right. Okay. Some of you giving the answer as A. Okay, this is not the answer. I hope it is for this question only. Okay. Chalo, let's discuss now. Pituitary dwarf. What is pituitary dwarf? First of all, that it is not the answer. I'm just telling you what is pituitary dwarf. Pituitary dwarf, when the growth hormone secretion is reduced by any reason via the acidophilic cell. That is pituitary dwarf. Hypothyroid dwarf. In the hypothyroid dwarf, what is going to happen? The thyroid levels are less, right? Obviously, and they are known as cretins. In the achondroplasia, what is the problem? The problem is in the fibroblast growth factor receptor number 3. Okay. In the Laron dwarf, the problem is in the IGF-1. Now, all of them are going to have the problem in the growth. Nothing is given as per the IQ. The height won't be increasing, but remember, this fibroblast, the growth hormone, and the IGF-1, they are water soluble hormones. The water soluble substances, they cannot cross the blood brain barrier. They don't have anything related to the brain development. Okay, and plus they don't have anything related to the metabolism also. They are only helpful for the linear growth, right? In the X, what you can see, there is obesity, right? Central obesity. Hairs, look at the hairs, there is a loss of hairs also, thinning of hairs. And if you see, it looks infantile, right? Or you can say it is looking like a 2-year-old boy, right? So that means this dwarf is none other than hypothyroid dwarf. Please do not get confused, okay? Unless and until they provide you anything with specific, the FGF is defective, IGF, don't go for Laron or don't go for achondroplasia. Please don't do that mistake, because we cannot clinically identify that what type of defect it is having. Okay, if they would have given us this, then we would have been confused, but they clearly ask about X, which is having that infantile kind of image, right? Loss of hair, thinning of hair is there, and he is golu molu, right? So he is having the central obesity also. The metabolism is reduced in this case. So please remember, and if they give IQ, then definitely the IQ of the cretins, it is low. In all of the cases, it is normal. The question, once there used to be a DNB exam, so in that they ask about Kasper-Hauser syndrome. You must have heard that in the medicine, Kasper-Hauser syndrome. In that also the patient will be dwarf, but remember that is the problem is not in the receptor or growth hormone, it is because of the neglect and psychosocial stressors. Okay, hopefully we are matured and then we came into the medicine, otherwise there must be a lot of there would have been a lot of psychosocial stresses to us too, right? Let's move on. This question, 42-year-old obese female, okay, type 2 diabetes, hypertension, bacha kuch nahi iske paas, she's having everything. Discuss an elevated level of prolactin, okay. She complained of galactorrhea, no menses for 2 years. The secretion of this hormone is controlled by. Now understand, that means prolactin is increased. The hint is over here. Prolactin is increased. Yes, please, answers. Dopamine, right. Please remember that the prolactin follows HPO axis, or the release of prolactin that follows. Now understand, the hypothalamus, through which it is going to have PIF or dopamine, which is going to control the prolactin. Prolactin is released from lactotropes that are also acidophilic cells. Just now we discussed anterior pituitary, right? Now what is going to happen? Organs are going to be the breast and other organs, right? Especially it is going to act on the breast and it causes the production of milk, right? P for P, production, prolactin, ejection, oxytocin. This PIF, what it is going to cause? It is going to inhibit the prolactin. Prolactin inhibitory hormone, that is nothing but the dopamine, that is going to inhibit the prolactin. Now she's having any problem in the PIF, and that's why the prolactin release is increased. Prolactin is also responsible for the lactational amenorrhea, which is there in the patient. Over here she's having no menses, okay? So amenorrhea is there because the prolactin is high, okay? In the normal lactating woman, it is causing the amenorrhea, which is called as lactating amenorrhea. Okay, let's move on to the next question. Vasopressin, all right. Following receptor, we have to identify which receptor it is there for the absorption of water through the aquaporin. So vasopressin, which is also known as yes, सब पास होंगे, जरूर पास होंगे. if you're doing hard work, so everyone is going to pass. Just keep this perseverance till the time of exam, right? Don't give up in between. Keep that determination high. All right. Right. I would have told you the shairi. If you're up for it, let me know. We can have one of the shairi over here also. Yes, please. Yeah, I would love to, if you guys permit. All right, so we're going to have three vasopressin receptor V1, V2, and V3. All right, so Homo, yes, Homo sapien sapien. All right, तो ध्यान दीजिएगा, लफ्ज़ कुछ ऐसे हैं. It is in Hindi, so the people who have problem in Hindi, I'll explain what does that mean. So it says that कौन कहता है कामयाबी किस्मत से मिलती है. कौन कहता है कामयाबी किस्मत से मिलती है. गर हो मेहनत में सच्चाई, गर हो मेहनत में सच्चाई, तो किस्मत भी झुका करती है. So please keep doing the hard work, keep motivating yourself, right? So that's all from my side. Let's come back to this V1, V2, V3, right? I'll be putting up a lot of shairis in my channel because that's free and no time foundation there, right? So you can go and watch there. Okay, I'll put 2 to 3 more shairis. All right. Okay, V1, that is going to cause increase the IP3 DAG. Increase the IP3 DAG. किस्मत लिखी जाती है बच्चों. So yes. Okay, I'm having a performance anxiety, so that was a bit odd, but okay, I can do better, right? IP3 DAG, this is by cyclic AMP. IP3 DAG, whenever it is going to increase, it is going to increase the calcium, what causes the contraction of afferent and efferent arteriole, will maintain the GFR, isn't it? Contraction. And GFR regulation may, it is going to help us. V2 will increase aquaporin 2, which increase the water reabsorption. V3, which is also known as V1B, we're not sure until that through which secondary messenger it is activating, but it is increasing the ACTH secretion. So please remember that. All right. Thank you guys. Thank you. This is the first time, right? All right. Fine. So they are asking about the absorption. So V2 aquaporin 2. Please remember. And they are asking the INI-CET people. This time they ask about the basal side. So please remember, some receptors, they are constitutionally present. That means they're always present. They don't have any role of the aquaporin, the role of the ADH. The ADH is going to act over here on the V2 receptor. It will cause the activation of protein kinase A via cyclic AMP and causes more and more aquaporin 2 to be embedded on the apical side. On the other hand, it has no role whatsoever in the aquaporin 3 and 4. They will be always there. It is having no role in the facultative water reabsorption, right? This through which the aquaporin 2 that is going to cause extra water reabsorption with the help of this hormone, which is known as facultative, okay? And without the ADH, whatever water reabsorption is occurring, that is called as obligatory. That is obligatory. Obligation is there to reabsorb the water, whether the ADH is there or not. Okay, clinical question. INI-CET 21, SIADH except clinically euvolemic, sometime there is known as Schwartz criteria, you must have heard of. Thank you guys. Thank you so much. All right. So Schwartz criteria, clinically euvolemic, sometimes hypervolemic. Serum osmolarity will be less than 275. Urine osmolarity will be more than 100. And the sodium concentration less than 20 millimole per liter. Now, understand SIADH except we have to identify what is SIADH. It is syndrome of inappropriate ADH secretion. You can remember it as syndrome of increased ADH secretion for the remembering purpose. Okay, if the ADH is increased, what is the function of ADH? To increase the aquaporin 2. If the aquaporin 2 increase, water reabsorption will be increased. If the water reabsorption is increased, that means more water is going into the blood. The blood is getting diluted. If the diluted blood is there, that means diluted plasma is there. That means the plasma osmolarity will be low. Right? On the other hand, urine will be concentrated, very high concentrated urine. That means the osmolarity of the urine is going to increase, isn't it? Urine osmolarity is going to increase. Now, it depends upon whether the patient is euvolemic or not, because initial cases, yes, he is going to be euvolemic because there is something known as escape phenomena which will be applied over here. Venous return, if it is increased, since the plasma volume is increased, there will be activation of ANP. The ANP causes natriuresis via inhibiting the ENaC channels, and that makes the person clinically euvolemic. That can be true, okay, but we have to exclude all other criteria. The serum osmolarity is less than 275 milliosmol. The urine osmolarity is more than, this is true, this is also true, right? The urine sodium concentration is less than 20 millimole with the normal salt intake. Urine osmolarity will be higher. Why you are answering C? Okay, the urine sodium concentration is less than 20 millimole per liter with the normal salt intake. Now understand, over here the urine is concentrated, and as just now I told you that what is going to happen over here, that because of this escape phenomena which is going to get applied over here, so definitely the urinary sodium concentration is actually very high. It is going to be higher. So this is not seen in the SIADH, and we have to apply our brain. Yes, the escape phenomena is seen in the patient because of the ANP. ANP is going to inhibit the ENaC channel. Please remember that this is going to take place. Yes, it is seen in the cons also, and this is seen over here also, right? The clinically patient will be euvolemic. There is a Schwartz criteria you must have heard of, right? Yes. Urine osmolarity is high, guys. So you cannot answer C. We have to answer except. Okay. So please remember this chart. Very easy chart I have for you. Just remember, if the ADH is increased, what is going to happen? ADH is increased and the ADH is decreased. What is going to happen? If the ADH is increased, SIADH, water permeability will be more, aquaporin 2. Water reabsorption will be more, the urine concentration will be more, since the plasma is getting diluted, since the blood is going from the tubules into the plasma, into the blood, right? And the opposite thing is going to occur over here, and you can see the urine osmolarity will be very, very high, okay? And the main reason will be loss of sodium also and less water, okay? So please remember that. Fine. Let's move on to the next thing, that is graph. Graph below, what it is showing. Alright guys, let's quickly finish this up. Alright. Now understand how to identify. There are three options which are running. First thing, urea. Okay. Now, over here, what is given on the x-axis? Plasma levels. Okay. And the clearance. As the plasma level is increasing, there is one substance, that is Z, which is having no effect. No matter how much is the plasma concentration, the clearance is constant. Okay. Over here, there is X substance which is increasing after some time over here. And there is one substance which is Y, which is having highest clearance at low plasma concentration. But as the plasma concentration is increasing, it is its clearance is actually decreasing. False low clearance. So what substances are these? Yes, please answer. Yes, absolutely right. Now understand Z substance. First of all, let's identify the substance. It is constant throughout. Doesn't matter what is the plasma concentration, it is constant. Remember about the inulin. Suppose, oh, I would have made it in a different color, so I'm just changing it. Bowman's capsule. Suppose this is the Bowman's capsule. Suppose this is the afferent arteriole, efferent arteriole, glomerulus and efferent arteriole. Okay. Now inulin is the only substance which get only filtered. It doesn't matter you increase the plasma concentration or decrease. It is not dependent on the plasma concentration. It is dependent on the filtration rate. Okay. So it is going to be constant even if we increase the plasma concentration, right? The fraction of the filtration is going to be the same, so it doesn't matter, right? So this is inulin, right? It is for sure, it is inulin. Z is inulin. And if you even identify the Z, look at the option. Option B is only having Z option in the inulin, right? They are asking respectively. And you see over here still, look at the concept over here, because we are not sure that these are going to be the order of the options. Now over here, this is the glucose. Why? Because after around 180 to 200 mg per deciliter, the glucose start coming into the urine. Before, the clearance was 0. As we increase the plasma concentration above the renal threshold, which is 180 to 200, which is the actual renal threshold, 180 to 200 milligram percent, right? Then onwards, this glucose is going to come into the urine. So definitely this is the glucose. About the pH. Now remember, the pH is filtered as well as it is secreted. For the secretion, we require transporters. And if we increase the plasma concentration of pH, these transporters are going to get saturated and they won't be able to work at their maximum capacity, right? And that's why the clearance is going to decrease, right? So this is going to be the pH. So X is glucose, pH is Y, and inulin, right? Right. Sorry. Oh, can't help it. Okay, I'll try not to do that. Okay, pH, glucose, and inulin. Let's move on. GFR is increased in all of the following condition except. Now, increase renal blood flow. What is going to happen? Decrease plasma oncotic pressure, efferent arterial resistance, and ureteric calculus. It's a very simple question though. We should know about the stalling forces. That's all. Suppose this is the Bowman's capsule. Oh my god, what all things you guys notice. Anyways, so suppose this is the glomerulus, and this is the Bowman's capsule. Hydrostatic pressure is present in both. Hydrostatic pressure is the pushing pressure. So if the hydrostatic pressure inside the glomerulus, it is increasing, it will increase the GFR. On the other hand, if it is increasing in the Bowman's capsule, it will inhibit, or it will rather decrease the GFR. Now, see over here, oncotic pressure is in the glomerulus, it is because of the protein. So, oncotic pressure is because of the protein. We can write it as pi. It is holding pressure. Why? Because protein loves to hold to the water. So, if the oncotic pressure is increased in the glomerulus, it won't allow the GFR to increase. It will decrease the GFR. On the other hand, if the oncotic pressure increase in the Bowman's capsule, it will drag the water from the glomerulus. But that doesn't happen in the normal case, since we are having negative proteins which are placed in the glomerular filtration membrane, right? So that's why what is going to happen, they are going to repel the negatively charged protein. So almost zero protein will be available in the Bowman's capsule and zero oncotic pressure, right? So increase renal blood flow. If we increase blood flow, what is going to happen? Yes, the hydrostatic pressure inside the glomerulus capillaries, it is going to increase, and that's why what is going to happen? The GFR will also increase. That's true. That's absolutely true. Decrease plasma oncotic pressure. If you decrease the plasma oncotic pressure, plasma means they are talking about this glomerular capillaries. So if you decrease the plasma oncotic pressure there, what is going to happen? It will no longer hold on to the water. It will cause more and more GFR, right? So that is also true. Efferent arteriolar resistance. If you constrict the efferent arteriole, the back pressure is going to increase. If the back pressure increases, that means the hydrostatic pressure over here is going to increase a lot, unless and until it is more than 3 times resistance. But they haven't mentioned it over here. It is having biphasic representation, right? But they haven't mentioned it over here. Unless and until it is mentioned, we are going to take it less than 3 times, which is going to increase the GFR in this case also. If there is a ureteric calculus, suppose this is the kidney and the ureter. This ureter will be connected to lot many collecting ducts above. That means it is connected somehow to the tubules, and in the tubules over here, let's say, I hope you can see this over here, you're having the obstruction, so it is going to put the back pressure, so the hydrostatic pressure inside the Bowman capsule increases. If that is increasing, it prohibits the GFR. So that means definitely the GFR is going to decrease over here. The answer, since we have to identify the except, so the answer over here is option D. Dr. Rao, it is not C. It is not C. Unless and until they mentioned it, we cannot say it is C. The best answer over here is option D. Let's move on. Which of the following has higher concentration in the urine after coming through the PCT? This question came in NEET 2021. Stupid question, but we have to answer it, isn't it? So, PCT. Let's see what happens in the PCT. First thing, that what they're asking basically is, suppose this is the Bowman's capsule, PCT. PCT is going to have convoluted and straight segment. Then the descending limb of loop of Henle, and then the ascending limb of loop of Henle, and then the further. Anyways, so if we cross the PCT, what is going to happen to the different concentration of these substances? Now understand, the glucose is reabsorbed by SGLT2 and SGLT1. SGLT2 will be present in the convoluted segment and SGLT1 will be present in the straight segment. That's not the question. Remember, glucose is 100% reabsorbed here. So almost 100% reabsorption of glucose, almost 100% reabsorption of the amino acids also. Chloride. What about the chloride? Chloride getting reabsorbed with the sodium. Sodium around 60 to 70% is reabsorbed in the kidneys, that is in the PCT, okay, and throughout it is going to be 95 to 97%. Sodium and chloride both are going to get reabsorbed, but only in the PCT we are having 60 to 70% reabsorption of the chloride. It is coming with the sodium itself. Bicarbonate. About the bicarbonate, we are having specific channels over here. We know that Ca type 2 is going to be present in the cell. Ca type 4 is present in the borders, that is brush borders, right, which will convert the bicarbonate, or over here it is going to be the sodium hydrogen exchanger, which is throwing out the hydrogen over here. This Ca type 4, what it is going to do, it will combine this bicarbonate and H plus ion, will cause the creation of carbonic acid, then it will convert it into carbon dioxide and water. They are going to move inside. The Ca2 causes reverse reaction from the CO2 water, production of carbonic acid. Again, it will produce H plus and bicarbonate. This bicarbonate, with the help of sodium, it will be reabsorbed by the sodium bicarbonate cotransporter. How much? Around 80% will be reabsorbed over here. Only 20% will go in the towards the descending limb of loop of Henle, right? So least absorb will be go more towards the after crossing the PCT. So the correct answer over here is option C. All of you are correct, right? Basic, please change your basics, right? All right. So over here it is going to be, they're asking after the PCT what is going to happen. All right. Diluting segment, very easy question. Diluting segment, very straightforward. NEET 2019. हाँ जी बताइए. All right. So descending limb of loop of Henle, ascending limb of loop of Henle, descending drinks the water. That means it is permeable for water, right? Permeable for water, that means it is concentrating the urine. Concentrating the urine since the water is coming out. On the other hand, we are having the sodium potassium 2 chloride. Sodium potassium 2 chloride exchange co-transport over here. So salts are coming out, right? So that is going to, but the water is not able to come out, so it is going to dilute the urine. So the ascending limb of loop of Henle, especially the thick ascending limb of loop of Henle, since in the thick we are having sodium potassium 2 chloride active transporter that is going to put the sodium potassium and 2 chloride, that is solutes, into the medullary interstitium, right? So the answer over here is option A. All of you are absolutely right. Okay, we are coming towards the end. For the following question, assertion and reason is given. The assertion is constriction of efferent arteriole can decrease the GFR, and the reason is more than threefold increase in the resistance decreases the renal blood flow, increase in the colloid osmotic pressure. Select one. Which one of the following is true? This came in the INI CAT 2021. Please remember that these type of assertion and these reasoning questions are coming recently. They are getting popular. Okay. So which one of this is true, false, whatever it is? So first of all, just identify whether they are related to each other or not. Constriction of efferent arteriole can decrease GFR. I told you that efferent arteriolar constriction, it is going to have a biphasic representation. If you constrict the, I'm writing over here of the next question. So first thing first, over here, let's see. Let's say, suppose this is the glomerulus and we are going to have Bowman's capsule. All right. And the GFR is coming from here. Now what is going to happen? Suppose I constrict the efferent arteriole or causes the efferent arteriole constriction. First of all, if the constriction is less than 3 times, the 3 times is mentioned in the guidance, it is very clear. Unless and until they mention 3 times, do not go for decrease in the GFR. Okay, so increase in the hydrostatic pressure. So mild cases, mild constriction of the efferent arteriole, what is going to happen is that there is increase in the GFR since the hydrostatic pressure is increased. But understand, if it is 3 times more or severe constriction is written, this question came in the medicine also, so please remember that. So 3 times increase in the GFR, 3 times increase in the constriction, what is going to happen over here is that the proteins are not also, they are not able to go towards the peritubular capillaries. The proteins start to accumulate over here, as well as the oncotic pressure start to build up there, right? Now understand, whenever there is a severe constriction, the increase in the oncotic pressure will be there with the increase in the hydrostatic pressure. But the increase in the oncotic pressure is more than the increase or the increment that is seen in the hydrostatic pressure, and that's why they will hold on to the water, and that's why what is going to happen over here is that there is going to be decrease in the GFR. The filtration is decreased since the oncotic pressure over here will be much higher as compared to the hydrostatic pressure, right? So that's why this is the truth statement, and these two are biphasic representation of efferent arteriole. Okay, no, that is not false. Both the things are true. Constriction of efferent arteriole can decrease when more than 3-fold increase, that means severe increase in the resistance, that's true. Renal blood flow, increase in the colloid osmotic pressure. Now they are not asking about GFR, they are asking about renal blood flow. Now understand, what do you mean by renal blood flow? Over here, I told you that the proteins are not able to go forward. That means the RBCs are also not able to go forward, isn't it? Because the RBCs are having more size. So, towards the peritubular capillary, that means towards the renal medulla and the cortex and the other parts, the blood is not able to flow since there is a severe constriction in the efferent arteriole. So, the renal plasma flow is decreased. That's true. GFR is decreased, renal plasma flow is also decreased. So, if I let's see what is the representation over here. So suppose this is the constriction, right? As you increase the constriction, what is going to happen to the renal plasma flow? As you increase the constriction, or let's say over here, rather than constriction, it should be, the better word is resistance by any matter. If there is a resistance, where we are talking about efferent arteriole, so renal blood flow, it is going to decrease, since as soon as it constricts, the blood won't be able to go towards the peritubular capillary, be it mild, be it severe. The renal blood flow is going to decrease in both. But if I talk about GFR, GFR will be increased first because there is increase in the hydrostatic pressure. But if the resistance increases 3 times more, then the GFR will also decrease. So this is how the biphasic representation of the GFR is seen, right? So that is going to be there. Okay, so both the things are actually true. Understood, guys? Bache, they are asking about efferent arteriole. Why you are talking about afferent? Afferent constriction, so GFR is going to decrease for sure. Yes, you are right, Dr. Rao. They are asking about efferent. Read the question carefully, bache. Alright. So let's see options. Both assertion and reason are independently correct statement. True that. The reason is correct explanation for assertion. That is also true. The assertion is independently correct. Reason is independently incorrect. It is not incorrect. This is the assertion is also correct, and so only left option for us is option A. Okay. I hope you got that right. Okay. This is a very recently asked question. This question is asked 3 times beforehand when the INI-CET was not there. In the PGI also it is asked. In the JIPMER was this was asked. Not in the NEET, but in the AIMS also this was asked. A very famous question. Alright. Understood? Yes, no, nod, thumbs up, something, right? So, okay, got it. All right, so we have come to the end of this session. If you allow me, we can have another shairi also, right? You must be feeling stress, you must be feeling anxiety, right? The only advice from my side is convert your worry time into study time. So jate jate ho jaye shairi, if you allow me. Okay, now what you can do is you can just study. Don't think that what if, what if I got this, I got that, right? Don't think about what if. All right. So what we are having in hand is to study. So अर्ज किया है, चलती रहूंगी पथ पर, चलने में मैं माहिर हो जाऊंगी. तो हमारे हाथ में बस पढ़ना है, तो पढ़ते रहिए, है ना? सो शायरी कुछ ऐसी है, चलती रहूंगी पथ पर, चलने में मैं माहिर हो जाऊंगी, या तो मंजिल मिल जाएगी, या तो एक अच्छी मुसाफिर बन जाऊंगी, राइट? सो प्लीज़ चलते रहिए, काम करते रहिए, स्टडी करते रहिए, राइट? डोंट वरी, डोंट अलाउ दिस वरी टू हैम्पर योर स्टडी टाइम, राइट? सो पढ़ते रहिए. दैट्स ऑल फ्रॉम माई साइड. थैंक यू गोविंद सर for always supporting me. Thank you Cerebellum for giving me this opportunity, and thank you guys for such a wonderful, such a active session, right? I hope for the more session, right? All right, I hope. Avoid the silly mistake, read the question twice. If you have any doubts, okay, don't jump into the answers, right? Thank you so much. So be positive, because thinking negative, having no gain, right? All the very best, guys, all the very best. Thank you so much, right? Keep the perseverance, and do not allow your psychology to, get here and there. All the very best. Bye bye.